กดในซูมก่อนดีว่ามันขึ้นปะขึ้นปะแล้วเสียงเข้าไม่รู้อะเสียงเข้า
เข้าดีครับพี่นัท
เข้าใช่ไหมอ๋อโอเคได้ยินแล้วใช่ไหมอัน
เข้า
นี้
ดีครับภาพชัดครับ
อันนี้ใครอ่ะ
เอครับ
อ๋อโอเค so I think we have this because in the beginning I don't have the Zoom link but now I put up the Zoom too so now it's 22 people in the Zoom because some of them cannot register but cannot travel here so it's okay with you it's okay if we record it too okay thank you so I think it is time now so welcome everybody we have to do it this in English because our speaker is from Argentina so I would like to thank you everybody I think we here in the Zoom is about 30 to 40 people so that's the number that I expected because this topic is I don't think it's that very common so only those who are interested in will be able to join so today we have a one-day symposium about the late reconstruction of a pelvis in acetabulum. It's our very great pleasure that we have our guest speaker today. So please give a big hand to Professor Carlos Sansineto. He's he's a head of orthopedic trauma from the Hospital Italiano de Buenos Aires, Argentina. He's a very well-known orthopedic trauma surgeon and a specialist in the pelvic acetabulum surgery. He also do a lot of other trauma as well. I've heard his talk about nailing, which is very good. Maybe next time we will have you talk about nailing. He's flown so far away from his home. I think it takes about more than 2 days for your flight here. So we appreciate it very much. So I first met him in Davos in 2013. That time we were both very young. I was a participant in the pelvic course and he was the faculty. So I was very impressed by the first time I met him already. And then a very good opportunity for me to meet him again in Madrid for the master's course in the proximal femur. So I get to reconnect with him again in 2019. So that was a very good opportunity for me. Again, I was a young faculty then, he was very well experienced. And the last time we met is in Chiang Mai just this year. So I was a co-chair of the pelvic course and he was our international faculty. So we very appreciate very much that he come here today. So you know that when you go to a course and then when you consult a case to someone, usually they just answer you like a small short note in the WhatsApp or the line, okay? But I was so surprised that when I sent him my case, and he was very serious about telling me and guiding what to do. And for example, this one very difficult cases, we have a 5 or 6 session of Zoom just to tell me how to do it. So I think that shows the passion of teaching, and I really appreciate it so much. So when we Zoom, usually it's late for me and in the afternoon for him because we have a 12 hours different. So we only for the one case we Zoom many times. So he changed my way of thinking because when I go and somebody asks me, I just answer short. So next time I will try to do better. So I think it's a very good opportunity for me and for everybody here to learn from him in such a difficult topics from such a passionate teacher. So we have to thank you very much for coming today. I think before we begin, I would like to ask Dr. Thana, our director, please give a welcome speech for him.
Dear Professor Carlos and all participants and also Dr. Rahut. I just know that you come from very far from here and you have tried to get our education to practice in the real practice about pelvic acetabulum course today. And I am very appreciate to have the chance to be the host of training in this course today, and hope you are all will be success and will train in this course. And also Dr. Carlos told me we can join together to change and educate knowledge together. Okay, I would like to say thank you to set here to be the course of pelvic acetabulum here today, and hope you will be success in the course today and everybody will be enjoy. Thank you.
So I think our agenda for today, in the morning, we will talk about the late reconstruction of a pelvis. And then we have some case presentation. And then we have a small session about the thoracic pelvis. And then in the afternoon, we talk about the acetabulum, and we will end with the 2 lectures from Professor Carlos. I think we are not going into theory a lot because you can find it in the books. Okay, so I think most of it is a case-based. We can learn from the experience of our speaker. Okay. On the Zoom, please mute your microphone, please. Thank you. So please, Professor, I will connect Wi-Fi for you so you can.
and all of you for being here and trying to understand a little bit about this topic of acetabular fracture care. And before starting, who we are. This is Argentina. This is in the southern part of South America. This is my country. That goes from the north to the south around 3,500 kilometers. And from Buenos Aires to Mendoza is around 1,200 kilometers. We have a surface area of 2.7 million kilometers square and a population which is smaller than yours, only 47 millions. And this is Antarctica. And you can see we are the closest country to the Antarctica Peninsula. And for that reason, we are claiming some of this sector of the Antarctica. Argentina is divided in 24 different provinces with different landscapes and animals or habitats and forests. This is the north, the limit between Argentina and Brazil, with the rainforest is the jungles, very similar to the forest you have here. This is the prevalent animal. This is a jaguar, bigger than leopard. It is the third in size in between the felines. This is Patagonia. You can see the opposite side of the country, we have a glacier area with a condor, which is the biggest flying bird, which is a special kind of badger. It's not, what's going on? It's not working. Okay, and this is the southern part of Argentina. This is the utmost southern part of the country. This is Tierra del Fuego, Fireland, where you can see whales and penguins. And in the middle of the country is Buenos Aires, the capital city, which is a relatively big city. The main district is 3.5 million. With the surrounding suburbs, we are 14 or close to 15 million. So this is a country of contrast. In the lands, you have the gaucho. The gaucho is a centaur, is a horse rider, is the Argentinian cowboy. In the main city, we enjoyed nightlife, and for the generation of my father was tango, and for the tourists, tango is well known from one of the interesting topics of Argentina. I don't know why it's not moving. I can. Don't worry. I can do it by myself. Then let's talk about the gaucho. Gaucho this is a drawing of the last part of the 19th century. The Argentinian cowboy, who is the descendant of the primitive inhabitants of the country and mixed with the Spaniards. So the gaucho is a mestizo who is the inhabitant, the natural inhabitant of the Pampas. Pampas in Indian language mean flatness. We say in America, Indian to Native Americans, because it was a mistake by Columbus. He thought he was getting into the India subcontinent, but by chance he discovered America. So this mix, this mestizo, okay. And this is very typical activity of the gaucho. He is pre-trade the horse, because horses were introduced by the Spaniard. And the gaucho as a horse has a festivity, la doma. And you can see they domesticate the animal, try to make a savage animal into a very calm one. And this is also the activity of the gauchos, but it's also a sport for them. They celebrate every year in different places this kind of activity to demonstrate who is much more brave, the animal or the man. But real gauchos are today like this, working in the lands, sometimes with pickup trucks, but still they are using horses. Horse is the best friend of the gaucho. You can imagine that the pampa was, and it is so flat, there were no trees at all. Pampa used to be like this, just grass. If you see trees in the pampa were planted by the Spaniards first and the Argentinians later. So it's like this African savanna, nothing in between the horizon. So the gaucho used to use the back of the horse to look to the distance. And to hear when that was a problem coming, he put the hair on the ground. And from this kind of personality, we've made our patriot armies. These are the gaucho from the northern part of Argentina, from Salta, the so-called infernals. These were peasants, working people that, in junction with local leaders, they defeated the Spanish army who first did win Napoleon in Spain. This is the independence of Argentina. So today they are using the same kind of dressing, and you can see that these gauchos has a different attachment to the horse, because in the flatness we have no trees. In the north we have bushes with the spurs. So the so-called, this is called guardamonte. Monte in Spanish is forest. So they are protected against the spurs. Gaucho is also someone who like to have, these are the two best friends of the gaucho, the horse and the dog. And because we have some wild animals very dangerous, not as you have here, we have wild boars and we have puma. They develop a special kind of dog breeding, the Dogo Argentino. Dogo Argentino is a hunting dog, and it's a hunting dog to protect the family and to hunt the wild boar. It's a very brave animal. 45 kilos of dog against 200 kilos of pig. And horsemen like to play on top of the horse. This is pato. Pato means in Spanish duck. Originally, this game was played with a living duck. Now it's a ball with 6 assholes, and then from the horse, the horseman is catching the ball. Then they are in competition which one is going to remain with the ball, and then scoring. And these kind of horses are similar like polo horse. Polo game is another interesting game in Argentina. We have the best number of, we have 40, which is a higher rank, but this is for rich people. So polo is for the owners of the land, pato is for the peasant. Let's go to the opposite side of our life, the city. This is Buenos Aires. The government house, we call it Pink, and the Plaza de Mayo when it's crowded. The people of Buenos Aires usually goes to this place to celebrate, to dispute, to agree about the politics of the government or to disagree. We are living outside. The main city is a living animal. And Buenos Aires is a very classic European-like city because it was founded by the Spaniards in the 16th century, and then at the end of the 19th century, the European immigration fulfilled the city of persons coming from all over the world, but especially from the Mediterranean region. And it's as sophisticated that we had one of the best opera houses all over the world, which is a Teatro Colón Theater. And when they are having something important in Alla Scala, in Milano, in Italy, at the same time it's coming to Buenos Aires, not only opera, but also ballet. This is part of the beautiful artificial lakes of the main city of Buenos Aires. And we also have a Japanese garden. The Japanese community donated this. So if you are in Buenos Aires, you can feel that you are in different places at the same time. You can feel that you are in Europe, you are in certain areas, so it's very similar to Miami, you are in certain area very similar to your country or Japan. And tango is one of our passions. My father used to dance the tango when he was young. Now, tango outside in the street is just to demonstrate tourists how do we dance, but it's not for persons of my generation. And this is the origin of my family, Castrovillari in Calabria, Italy. So you can imagine when my great-grandfather immigrated from this limited in size and poor town to Buenos Aires, how he was surprised having everything in a very distant country in South America. And this is our passion, not only tango, football, soccer. We don't call it soccer, we call it football. And this is Messi, and you can see many of them, as myself, we are Italian descendant. The Italian descendant people in Buenos Aires, we are around 60%. So Buenos Aires is the biggest Italian city all over the world, even bigger than Rome. Oh. Finally, all of us in a melting pot called Argentina, we have the same spirit. We are a little bit horsemen. We like our dogs. We share the friendship with them. And I would like to share this opportunity with you to demonstrate what we are doing in a so distant country. And then you're going to recognize that sometimes we have a lot of similarities in between you and us. So let's move to the lecture itself.
อยู่ปะไม่เอาหน้าซูมอันเนี้ยขึ้นโปรเจคเตอร์ไงที่ออก
So before talking about leg reconstruction, we need to have some previous organizing. And I thought that to talk about the spectrum of stability of the pelvis is going to help us to understand what are we going to discuss later on. So the objective of this lecture is try to recognize the type of instability, to recognize the time for reconstruction, to identify techniques of release and reduction, to understand limitation of assembly. What's the concept of being stable? Stable is able to sustain physiological forces. So if you have a given fracture and you want to try the capability of the fracture to sustain physiological forces, you're going to understand where it is unstable and if it needs or not to be fixed. So there are fractures that are going to be stable to be lying supine, but unstable to be sitting. Some other fracture wants to be stable seated by not walking, and there are fractures that are unstable in any circumstance. For instance, if you are the patient arrived to your place and you take a AP view and there is mild displacement, this fracture is unstable by definition because he cannot walk with this displacement. So for me, when I consider this, I am organizing in my mind my strategy. Where am I going to regain stability? But which kind of implant am I going to use? So what I'm going to show you is part of my history with different kind of implants and different kind of stability. So you have to recognize from the very beginning that there is no intrinsic stability in the pelvic girdle. So without ligaments, the bones are going to come into a part piece by piece. So when we are talking about instability, we are talking about fractures and ligament disruption. So, and then there is a systematic approach of where the pelvis is unstable. So I like to use the classification developed, which is an anatomical concept developed by Le Tournelle and then used by the German school, which is subdivide the pelvis in different areas and define this is transpubic, transforaminal instability, transacetabular instability. So it is telling you where it is broken and where should be reconstructed stability. So we search at the level of the pubis for obturator foramen, hip joint, alar, SI joint, and sacrum. So unstable is unable to sustain physiological forces. So as I said, there are lesions stable to be at rest. Those are stable to be seated and then to be standing. So weight transfer is different than standing or sitting, and we need to know this situation. And this is a result of unstable situations treated by conservative means. That is 1990. This is unacceptable. But very often we are going to see cases similar to this. So if we recognize where it is unstable and which is the result of a non-surgical treatment or inadequate treatment because the point of instability wasn't properly addressed, we are going to think in the reconstruction by surgical means. And by surgical means, it's mandatory to recognize which are the structures and the risk. So, and this anatomical illustration, you can see that everything is very close to the SI joint, artery, vein, roots. There is a very narrow space to work, and the surgeon has to be familiar with all different techniques in reduction and fixation. First set of techniques is open reduction of the interlinear fossa, do direct reduction of the SI joint, and fix with plate. That was a very traditional way to do it. And you can do it just with plate, or you can increase the stability by using intramedullary screw. This is a very old case of my series. Still, I was open the internal iliac fossa personally speaking today. If I can avoid it, I try to do it close. And this is another very old case. It's a floating hip. You can see the displacement of the SI joint and the X fix in place, and you can see that cranial migration cannot be addressed by the external fixation at all. So this is something you have into consideration. If you put an X fix in place, you're very sure to fail in containing vertical instability. So it's going to be helping you from the very beginning, but you need the secondary reconstruction. So this is what happened with this patient. And you can see in this part of my personal history, that was the changing from sacral bar, that was one of the standard of care, providing stability behind the sacrum, into the screw, providing stability under compression through the SI joint. So first, strategy was the plate, then plate plus a screw, then sacral bars not to open. Closed means, today means percutaneous screw, but there was a period of time in between that the reduction was done by open means and fixation was done with a screw. And sometimes we didn't perform anterior approaches, we just uses X-fix to control the anterior instability, because at that time it was considered that the pelvic has 3 different levels of stability of 3 different columns. The anterior component or the anterior column of stability was the pelvic symphysis. The second component was the anterior part of the SI joint, and the third component was the posterior aspect of the SI joint, where is the most complex association of ligament, which is the posterior ligamentary complex. So by doing this, you need to learn where to go percutaneously. And then you need to be aware of close maneuver for the reduction and fixation. And if you are doing so, you can fix such a fracture by closed mean and percutaneous fixation. And then you have stability in the front by the screw, stability in the back by the screw, and you can treat fractures, crescent fractures, just with the screw alone without opening. So that means a change in the paradigm or the paramount of how to treat this kind of fracture. And you can also prove that vertical and stable fracture like this can be treated just with a screw alone. Take a look. It is a fracture of the sacrum, widely displaced, quite unstable, with comminution, close reduction, percutaneous fixation. When the fracture was already healed, we removed the anterior column screw in order to have a much more nicer modulus of stability of the acetabulum. So with only 4 screws, you can treat such a vertical unstable situation. But again, that patient was able to be resting. He had to wait for a while to be sitting and even longer to be walking. But that was the way we did address the problem. And you can see here, this is a late reconstruction of another patient who suffered the treatment of external fixation and secondary displacement with this situation and the quality of the reconstruction. Another type of stability that was in the front, because screws weren't enough, we add stability by the use of the tension band plate. This is a very stable construction, much more stable than the screw alone, and it is replacing the sacral bar, which are bulky and not always available everywhere. You have plates everywhere, so you can increase the stability of your construction by the use of this sacral, this tension band plate. So let's go to this case. Stable or unstable? Who wants to treat it? You? You want to treat it? Yes, go ahead. Volunteers,
Volunteer, please.
because we are here to interact.
Yeah. Want to try?อาจารย์บอสละกันอาจารย์บอส I choose for you.
So for this one, we can see that the left hemipelvis is superiorly translated, and we can see from the front that the superior and inferior pubic rami on the left is also superiorly migrated. On the back, I am not sure about the fractuli, but looking at the outlet, so maybe is this an SI joint, but I'm not very sure. Maybe like a really lateral fracture of the sacral ala or the SI joint dislocation, but there are not really any opening.
So it's
unstable in my opinion.
unstable.
Yes.
Okay. And these are the points of instability in the front. And then This is instability in the back. Okay, how do you treat this? Are you from here, from Bangkok?
How long?
Are you from here, from Bangkok?
No, from PSU, from the south.
Okay, so how do you treat this in the southern part of Thailand?
Okay, so in
Skeletal traction, bed rest,
so
sling,
as an acute case,
nothing?
right? Acute case, right?
Yeah, this is, today is acute.
Okay,
If you wait too long, it's going to be a late presentation.
all right. So we would do the skeleton traction on the distal femur.
Okay, and
Uh-huh.
for how
Initially.
long?
No, just for the initial, and then do CT scan probably,
Okay,
and then plan for operation after.
okay. You put a patient in skeletal traction because you consider that this is going to improve the quality of your reduction, or because you have to wait too long for the patient to be operated for any reason, medical reason, bureaucratic reason, lack of well-trained surgeons. You need to give a phone call to Rahut, come to the southern part of Thailand because I need your help, and he's very busy. He was in a course in Singapore. He's going to be available in 2 weeks. Why did you put the patient in a skeletal traction? Which is the rationality? Every answer could be correct.
Yeah.
And you can mix all together, but I would like to know why skeletal traction.
So for us, I think usually we don't operate them right away.
Okay.
So using skeleton traction could give you some reduction and retention of the fractures while we are waiting for the operation theater, probably in maybe 3 or 5 days.
Okay.
So
it's going to change so much if you put the patient in traction for 3 days.
I believe it would make it that because the fracture would kind of a little bit reduced compared to if you let them to be displaced a lot. So the soft tissue condition and the pain would alleviate a little bit.
So if this is cranially migrated, it has an eponym. What's the name of this kind of fractures?
Vertical shearing?
The name, it has the name of a French surgeon, Monsieur Malgain. This is a Malgain fracture. Malgain fracture is a vertically displaced pelvic fractures, and the spelling is Malgaine.
Oh,
He described this vertical displacement before Herr Rengen discovered the X-ray. And there are 12 different combinations of Malgain fractures according anterior, posterior, ipsial, or contralateral side. So you want a CT, and you have a CT. So again, stable or unstable? What do you think? Unstable. You're absolutely sure. Okay. Who is going to treat this patient just with a skeletal traction? No more? When I was a resident, these cases were treated with a skeletal traction, because what we knew, according to Malgain, is that if these vertical shear fractures, they are on day one very easily to reduce, but they are very difficult to be contained. So the skeletal traction helps a lot for the reduction, almost anatomical reduction, just by doing nothing. But the skeletal traction should be placed in a special way. There's no support in the ischial tuberosity, and avoiding to damage the soft tissue of the anterior aspect of the knee. Should be flat. So you need to make a special construction, because if you flex, it's not going to work, because you are flexing, you are putting the thigh in the traction device. It doesn't matter which is the name of the blue or brown construction, and then the canter traction is not going to be proper. The problem is, as soon as you release the traction, it is going to be upright again. It's like a spring. Okay, but this kind of fracture, because it's this kind of lesion, because it is a fracture through the sacrum, is going to heal in between 6 and 12 weeks. And this is the period you need to protect the patient in a skeletal traction. So if this is a different kind of animal, if we are talking about SI joint dislocation. Oh, okay. What happened? It disappeared the screen. Is there something? Okay. Well, he is fixing the internet connection. So why you are not going to treat the patient from the beginning until the end in a skeletal traction, if it's going to heal anyway, which is the reason? Why not a skeletal traction until healing happens?
So that would be like a really long-term immobilization, and also there's might be a risk of non-union, I think.
No, it is very probably that if your skeletal traction is well balanced, this is going to heal very nicely. The problem, you need to put the patient in skeletal traction for 3 months. And during 3 months, you are going to be by some other kind of set of complications. But if you are living in a developing country like mine, you know what's the definition of developing country? You don't have a national standard of care. So in some places it's very sophisticated, in some others it's very low. But if you are living in developing countries and you have no resources means you don't have good machinery, you don't have good implants, you don't have good surgeons, and you are a general orthopedic surgeon, and you want to treat this fracture, you put the patient in skeletal traction for 3 months, it's going to heal. The problem is, for the patient, the capitus ulcer and the risk of deep vein thrombosis. And this is something we don't like to have. The other problem is for the system. This is extremely expensive to block a bed for 3 months, because we need to make the turnover very fast in order to avoid someone else to receive treatment. But in certain countries, patients remain in-house until the end of the treatment, even though they have been operated. In some other countries, for instance, in my hospital, okay, in my hospital, we have a system. After the surgical procedure has finished and the patient is in the safe zone, we send the patient back to his home, and we send doctors and nurses to take care of the patient at home. So we increase dramatically the capability of the institution to continue treating patients. So each situation is different, even in the same country, maybe even in the same neighborhood, because my brother is working in a public hospital 10 blocks from mine, and it's a completely different kind of conception of treatment. This is developing countries. But at least what we need to know is that we need to avoid cranial migration, because it's going to create situations like leg discrepancy, sitting imbalance. So in the best scenario, you are going to do surgery immediately. In the worst, you are going to wait till healing time of this fracture in the skeletal tract. Okay. So what we know since 2010 is that if you have an incomplete sacral fracture with ipsilateral ramus fracture, have few possibilities of secondary displacement. Complete sacral fracture, however, they have high possibilities of displacement. So reducible or not? Let's try to take care of this patient at the same time, you and me. I know there is someone from Philippines that is very interested. So yeah. You can you reduce it or not?
I think if for example after doing the traction, yes, you can reduce it because the superior displacement doesn't seem to be too big. So in what I've seen during my fellowship training, after reduction, and if you get to prepare the implants, then you could put a posterior screw fixation over the S1 and S2 if needed. And then you could also do percutaneous screw fixation over the anterior, or you could put the plate to fix the anterior displacement.
Choice.
Because in the Philippine setting, we don't have enough implants yet. So probably if I get to do this in the setting of the Philippines, then we have short screws to put the posterior screw fixation to fix the posterior ring displacement, and anteriorly, probably we can put the plate.
A plate.
Yeah, in our setting.
Okay. Is everyone agreeing? Screw in the back, a plate in the anterior component of the fracture. Who is going to put the screw in the front? You? You look like you like screw. Do you like screws or plates? Okay, but please, you need to help me to content someone. Yes. Okay, don't have experience, but you have imagination. Screw or a plate?
I think screw it can be placed if you can reduce it properly.
So open reduction or close reduction?
I think
forgot to
I think it can maybe close wide.
close.
Yeah.
Okay.
Of the leg.
He wants to, yeah. You, don't look at that. Yeah,
Me?
yeah. You don't have experience for percutaneous screwing,
Yeah.
and you have no clue how to open the inguinal canal. Is there any other possibility for fixation of the anterior component?
Material component. The first thing is if we cannot reduce the rami to give enough the corridor to put the screw, I think better with the plate.
With a plate?
Yes, but if we
Are you familiar with the ilioinguinal approach?
not too much.
Okay, no,
Yes.
please. Don't kill the patient. Suppose that we are here to save life, not to kill them.
Yeah.
So your corridor is not perfectly defined, and you don't have experience to open the ilioinguinal canals. So do you have any other thing in your hands to help this patient?
Mm,
Because otherwise, you need a skeletal traction.
if I don't have if I have the limit resort and unable to refer patient, right?
No
Maybe-
different patient. No, this one.
Or this one. Maybe just external fixation.
External fixation is a good tool. So that's the reason I show you in previous cases, different possibilities of combination. You have to choose what is possible to use in your hands according to the level of training you already have. So if you don't have any training at all because you're a general orthopedic in a small town and you only have a drilling machine and a Steinman pin, just a skeletal traction, that's it.
Yes.
And prevent secondary displacement, because secondary displacement, the leg reconstruction, it is much more complex than primary care. So if you cannot attend primary care properly, you're not going to be able to resolve the complication. And it's much more expensive for the system, because sometimes you need to release everything, put the patient in skeletal traction, in late reconstruction, wait 1 or 2 weeks, very high complication rate in terms of infection. And if you put this patient in skeletal traction for the very beginning, and it is absolutely reduced, and you wait 12 weeks, not 3 weeks, 12 weeks until it's absolutely healed, the rate of complications is going to be very low, but you need to pay a lot of money in heparin or anticoagulation treatment. Your bed is going to be blocked. So you need to balance your decision according to your resources. So any other possibility of surgical treatment for this patient? I need a volunteer. Rahut, go ahead, kill someone. You were in Chiang Mai, isn't it? Yes. Okay, so you know everything. Come on. Let me know.
You mean aside from screw in the back and screw in the front and plate in the front and X-fix, right?
Yes.
Or
Whatever you want.
anyway.
You can tell me that you are going to put the patient in a pelvic sling or whatever, or you are going to do something different. You don't need to agree with me. I didn't come here to be applauded by you. I came here just to
Okay.
pinch
I think
pinch you.
if
pick
this were my patients, I think the vertical sharing component will be reduced by skeletal traction, like Arthur mentioned. I think, but I would like to emphasize that if it were me, I would like to put 2 screws in the back.
Okay.
And since I joined the pelvic course already, I think you teach me quite well, so I'm quite familiar with the inguinal already. So I would prefer the plate.
A plate.
In front, yes.
Okay, so a plate in the front through the inguinal. What? So that means that you're going to operate supine or inguinal.
I'm quite more familiar with supine.
Okay. So if you're going
than-
to operate supine, how are you going to fix the sacral fracture?
I want to confirm it with the CT scan anyway, but if it's quite reduced already with the skeletal traction, I think intraoperatively we have some corridor to put 2 screws. Then I think the sacral posterior tension band plate is not that necessary in this case. But if there were some comminution or any displacement that preclude me from placing the percutaneous screw supine, I may need to flip the patient over and perform open reduction, but I would like to do that as a last choice because 1, I don't quite familiar with that approach, and 2, I think the skin complication, soft tissue complication is much higher than just percutaneous screw.
Okay, so if I understood properly, so it's going to be supine, anterior approach, inguinal approach, reduction of the anterior component, checking the quality of the reduction of your posterior component, percutaneous screwing for the posterior component, and in case you cannot find a safe corridor, you're going to put the patient prone and percutaneous fixation after close reduction. And I said percutaneous fixation after close reduction because you cannot put the screw through the incision because it's very hard to mobilize a whole flap. It is easy to make the flap. You have seen the flap development by Rahut in the practical exercise in Chiang Mai. You develop the flap, you reduce, and then you make small incision laterally and you find the safe corridor. Okay, I like your approach. And you don't like tension band plating?
I would, since availability of this long full thread screw in Thailand is quite ready.
Okay.
Yeah, so, and if it's not to this place, I think I would prefer percutaneously fixed rather than open it.
But you have already opened the whole gluteus maximus flap. So you are already there, so you can slide
if-
the plate a little bit and make
Yeah.
a small incision this side and the opposite side, and you have a tension band
Oh
plate.
yeah, if I already open reduction and have the approach ready, I may prefer putting the plate. But
Okay.
yeah.
Any other comment from here? No comment at all? Okay. May I have a different point of view or slightly different? So you wanted to see why do we have here these images? Because we have money to buy them. We have already bought the CT scan machine, and then we like to have this. Is there any relevance in having this view for those who, not for you, you don't need to move your head because you have, you have already said that you like looking at an approach and a place. So for you, it's irrelevant, this view. But who wants to put a screw in the anterior column? You. So for you, it should be highly relevant to have this view. Why? Yeah, highly relevant.
For the corridor, when we
Yeah.
want to check,
Because you have comminution here, which is not the best situation for the screw, and then the corridor itself. What happened with the corridor?
if it's superior translation, so the corridor gets smaller for the screw.
Yeah, but it's something which is previous to the translation. It's the shape of the iliopectineal eminence. Some patients have a very straight anterior column. Some others have the protrusio acetabularis. When you have protrusio acetabularis, the iliopectineal eminence is like this, like a hill. So your screw cannot reach a proper position. And if you are still a screw maker, you can develop a different conception, which is not put it intramedullary, but you can put the screw behind the acetabulum with the in-out-in technique, which is much more dangerous, much more sophisticated, sometimes equally stable. So this should be understood before going to the OR. And this is the pre-op planning. Okay? Any concern from your side here?
So
No.
I have one question, Professor.
Yeah.
So I have one experience with the in-out-in that you mentioned. It's quite stable, but that one was a mistake. I mean, it's not intentional, but it works anyway. So I'm not sure, like, because all of the neurovascular is there, right? If we do it in-out-in, so how do you like plan if you are going to do something like that in the in-out-in manner on the anterior side?
This is a good point, because we have here artery and vein. If your technique is in, out, in here, and you are engaging the iliopectineal eminence here and the artery and vein here, you can damage, but you can do the in, out, in posteriorly, where it's relatively silent. Because once it happened,
So it's
you have
out
to
in the
profit
medial.
of any problem in your life to try to convert it in a profit. For instance, you have an open distal femur fracture, then you're going to operate through the open fracture. So the trauma has done the approach by yourself. Don't try the traditional approach. Now you have to profit. When it happened to me, this situation, I checked the stability was okay. And then I did remember that Reinhold Gans is using the in-out technique for the fixation of the periacetabular osteotomy. So from the very beginning, we have our mind restrained to it should be inside of the bone all the time. But if this outside of the bone and it is stable enough and it's in a safe zone, why not? This is to be use your mind as a parachute. It should be open to work. Any other question? Or a
Some
comment?
sorry. So
You
I
can
think
tell us that you don't like.
no,
what
I
we
like
are
it,
doing.
but I think this case is the more important thing is you need to reduce the lamine fractures in order to get a very good corridor. And if you are not sure about it, if I'm not sure about the corridor that I can put the screw or not on the front, I can check the size or the track of the corridor on the normal size. So if I check it before and I realize that it's not possible, so I go for replating. But the key in this case is open induction of the lamine as well.
Yeah, you're absolutely
Yeah,
right.
yeah.
So that's the reason why we need different views and check different possibilities. So don't get surprised in the OR. You are in the OR, you need to confirm everything you thought in advance. Okay? Try to make a long story shorter. So, sacral fraction mass reduction on the safe plane of the sacral screw. It seems that the reduction matters because you can define a safe corridor. Reduction deficit larger than 1 centimeter were associated to a bigger incident neurovascular lesion. Okay, now I'm introducing you a new concept, triangular osteosynthesis. And this is what we have done. We have made a close reduction. We put a screw in the safe corridor of S1 to a screw. We put a retrograde screw in the anterior column, and then we neutralize everything with a spinopelvic instrumentation. And spinopelvic instrumentation was performed with the patient prone, and after the reduction was obtained. And then this is a neutralization strategy, it's not a reduction. We do not reduce with the spinopelvic instrumentation. When everything is already reduced, we fix it. So this is increasing the stability because remember 1, 2, 3, 6, 4, 5, and 6 areas of potential instability. In this patient, we have 1 here, 1 there, 1 here also through the foramen. So we stabilize each one of the different points of instability in order to obtain a construction that is stable to be sitting and even to full weight bearing. The problem is some patients, because of they are polytrauma patients, they cannot be standing next day, even though the construction could be strong enough for that. But this is a strategy that when you do it with relative consideration to the soft tissue, it's going to allow, if this is an isolated lesion, to send the patient back home after 72 hours. And you can compare 72 hours against 12 weeks. You know the amount of soup in 3 months, that means 12 weeks the patient is going to consume in the hospital, a lot of soup. Now he is going to his house and he's going to be eating at home. And the bed is ready for someone else. So we are surgeons, but we need to have into consideration that we need to think about the other patients who are not going to be ours. In this case, stable or unstable? You don't agree with the previous treatment?
Can I ask one question about the post-op X-ray last case? So if I can put 2 TITS on the back side,
You mean
very long screw that catch 6 cortexes, 2 screws, transaerial transacral screw.
to reach here?
Yeah, and the iliac wing on the right.
It could be probably stable enough.
Do we need to, if I can do like that, do we need to put the triangular fixation or not?
It's a good,
in your opinion, yeah.
It's a good question.
Yeah.
But I don't have a good answer because maybe it is stable enough. However, I'm not going to allow the patient to full weight bearing with this construction.
Okay. Okay.
So
okay.
it is stable to be resting in bed
Okay,
or even
okay.
to be sitting maybe, but not to full weight bearing. This is the only construction to allow the patient full weight bearing. But in the other hand, I'm going to tell you some limitation we have at home. We have, it's a matter of trading. We did request several times for the importers to bring us long screw, 160, 170, 180. But because this is a very limited market for this screw, they are not importing them. But in the other hand, a spinopelvic instrument, this is very profitable for them. Because every single spinal surgeon is going to put at least 2 or 3 levels of instrumentation. That makes money go around. So for that reason, you have a variety of spinal implants and very limited pelvic implants. So in order to avoid to jeopardize the end result because lack of appropriate length of the screw, I emphasize in the use of percutaneous or semi-percutaneous treatment with the spinal pelvic instrumentation. What I wanted to hear from at least one of you young surgeons is for how long this spinal pelvic instrumentation is going to remain in place. Well, okay.
Usually my spine colleague does take it out around 1 year spot of, yeah, 1 year.
Well, okay, because we are not fusing L5S1 joint or space. We are just bypassing the fracture. So at the very beginning of my practice, we did, or with this kind of construction, we wait 1 year. Several patients in this year started to suffer low back pain. And when I did remove the instrumentation, it was also to remove it like this because it was a loosening in L5 pedicle. So literature at that time did support 1 year waiting time. I said, look, why do I need to wait 1 year if the sacral fracture did heal at 3 months? Now, then I started 6 months and check what's going on. Nothing happened. Now at 3 months, I removing. Sometimes the patient is not coming exactly at 3 months. But if at 3 months, this fracture that wasn't the most unstable is already healed, why am I going to wait 1 year and have a much more difficult procedure for the removal and damaging the pedicle and having a patient with a more restriction in movement? Okay, this is the rationality because I want a free L5S1. Questions? Any other question, proposals? Do you agree, Rahut?
Yes.
Please don't be so polite. You have to disagree from time to time.
Yeah, but I think nowadays we just put the long transil sacral screw. We have a lot of the long screws.
Because you're a rich country.
No, no.
And I was expecting someone tell me that this screw was very big for such an anterior column.
So that's in-out in screw, right? In the inlet view.
It's not exactly in, out, in, but it's very close to in, out, in. Because one of the tricks, so in the CT, the idiopathic was not as curved, but still the relationship between the size of the corridor and the screw were not as such a big corridor. So there is a trick. Several times what I'm using is 4.5 millimeter long cortical screw, solid screw, because we have 130 millimeters. The problem is if the screw tries to exit through the fracture line, it is very difficult to find the opposite part of the fracture because it's a solid screw. So the trick I developed is first you can slightly open at the level of the fracture line. That is a little bit dangerous, but it's not extremely dangerous. Let's see. You can see here iliopectineal eminence. That's the reason why I put this picture. Artery, vein. This is, you can use a stop approach or a fantasy incision to put a plate here, but your plate is going to be reaching here. No more laterally. And you are beside the vein. And the screw is very difficult to be positioned here through this approach. So we develop a trick. We have here the abdominal wall muscle, rectus abdominis. Here, this is the end more or less of the rectus abdominis. So I palpate. This is was my first attempt. I did palpate the rectus abdominis through the fantasy incision. I recognize there is blind spot, which is similar to the blind spot of the end of the pararectus, which is a blind spot of the or silent spot of the lingual approach, which is getting into the fascia transversalis. So today what I do is, because I did recognize by dissection this before, I palpate my rectus even without opening here. I know I'm here, I open the skin here, I make the dissection, I put my finger to recognize where is the fracture line. I try to help the reduction with my finger or with a small hook. And then if I'm not able to put the 4.5 cortical screw, I put the K-wire of the cannulated screw. The K-wire of cannulated is for, in this case, it was a 6.5 cannulated screw. That means much bigger than the 4.5. However, when it is well positioned, I use the cannulated drill bit. So I'm rectifying the curvature of the anterior column. And by rectifying, sometimes I move a little bit medial because this is a silent. So it's almost in, out, in. And then I'm engaging the solid part of the opposite side of the fracture line. So when you cannot use solid screw, you can work, this is it's a nailer concept. You put the K-wire and you prepare like nailing a tibia. And so you bend the tip of the K-wire and you rotate until you find a nice spot. Then you hammer it, then you use a cannulated drill bit, then you follow with a screw, and then you can improve the use of the screw in those places where conventional 3.5 or 4.5 screws that are not easy to be used. Is that right? This is not written in the manuscript. It's not in the Bible. This is just tricks I learned by doing. Okay. Now I need a volunteer.
Okay, I think this
But
one.
when you're discussing in between you, I'm going to drink a coffee. Because I need it.
Actually, we have also coffee break, but next one. Dr. Rahut, please.
Good morning. I'm Norashad from Ramathibodi Hospital. So in this case, I think the radiograph shows posterior elements posteriorly displaced, and it go a little bit upward, which is I'm not sure that the anterior side is a fracture through pubic tubercle, and pubic symphysis is intact. So I think it's highly unstable, and the fracture line posteriorly is go through in a outlet pelvis, go through sacral alars, and it's difficult because of that quality of the radiograph is too underexposed. It's a true, I think it go through a sacral foramen. So it should, or for the planning of the initial treatment is I will use a skeletal traction too. And then when operating room is available, the condition of the patient is stable enough. One thing that I will caution is about the size of the patient also. I have the experience of reducing it via in the supine position in a big patient. I cannot reduce the posterior element, and I have to flip the patient in the prone and open it and use an instrument to reduce via the posterior approach of the SI joint.
Okay, this is a good point. Why the size of the patient matters?
It's a huge, when it's huge.
What does it mean huge? Because you type people, you are not very fat.
At that time, is a special patient. He was 120 kilogram.
Okay.
Yeah.
And
is the exterior looks like this. And
what is the difficulty in someone who is 120 kilos?
Because
because it's very heavy.
Pardon me.
Because the patient is very heavy.
Yeah.
But it's very heavy, supine or prone.
I prefer prone to.
Why?
Because the instrument to reduce it could directly reduce it. But at that time I go.
Could you show me how is the setting in your hospital for such a patient?
What do you mean setting?
The setting, yeah. This is the setting.
Yeah.
Okay. Select one of your colleagues.
The next who's sitting.
And position, and let me see how do you proceed.
Okay, come on. My colleagues, his junior colleagues come together. He's my junior colleague and they work together.
Okay.
At that time, I do it.
He has the obligation to say yes to your proposal. Otherwise, he get punished, isn't it?
No.
Okay, do it. Your job is in risk.
So at that time,
do you put the patient like this?
No, in the flat
out?
on the flat table, and
Okay.
at that time I opened through the anti-SI element.
This is your setting. Are you satisfied as a surgeon?
Not sure. I might ask your suggestion also. And I put a bump beneath.
Okay. How?
It's just in
longitudinal or transversally?
Pardon me.
Do
Longitudinal
Okay.
to allow the space for
Okay, perfect.
putting the screw in.
And
I open because when I do the closely reduction is not part.
what about your table? How is your table?
It's a radiolucent.
Okay.
And they put
It has a pegging in
no, nothing, because I put the base of the table on the top.
So and
It's
what about the width of the table?
With there's the one problem that I have met, that if the table is too wide, when you insert the screw is
This is one. So may I suggest
to lean to the side.
So you have more. Be a good patient. So ideally, the patient should be
close to the side.
very close,
Mhm.
and the table should be very narrow.
Mhm.
If you have such a condition and nothing in between, underneath, you can obtain AP, outlet, inlet, other, an autorated view, and you can interchange position very easily.
Mhm.
But the problem is when the patient is very big and it's in the middle of the table, sometimes you cannot hit the safe corridor. And if the table is very wide, the round part of the C-arm is hitting here.
Mhm.
So we made a wooden table.
Wooden?
Yeah,
Really?
which is very narrow. It
Mhm.
should be the size of the pelvis and no more.
Mhm.
And then you can increase your possibility.
Mhm.
You can buy a $200,000 table, but with a wooden table is only 200. And then the opposite side. Don't be, no, anesthesia, he's sleeping too deeply. Move this to show them. Little bit more. Okay. So if I were the surgeon, sorry. A little bit much more here,
Yep,
closer
maybe.
to the border. More. Okay, that's fine. We are here. And then, since the patient is located like this, you can put a screw with this trajectory. And this trajectory, which is very posterior, in the case of cranial migration, usually when you have a vertical shear fracture or a dislocation, it's cranially migrated, but also is posteriorly migrated. So for the reduction, you pull the leg, or you put a shunt pin in the iliac crest or in a supracetabulum and you pull directly. And once the safe corridor is developed, your screw is going to be like this, from posterior to anterior. So it's going to be reducing the dislocated SI joint. But it is only possible if the patient is positioned like this. If you elevate the pelvis with something that which is underneath the lumbar spine, because when you are lying supine, your buttock is like this, but you elevate the lumbar spine, your buttock decreases in diameter like this. And the old instruments I did measure, but not the new one, instrument for the 2.7 kinetic screw were only the K-wire 23 centimeters. Now it is longer, I think it's close to 30. But several times, 23 centimeters were very short to hit S1 body and have enough metal outside to find in between the soft tissue. That's your problem?
The one problem that when I try to reduce, even I use a chance pin I put a chance pin in the ilium and try to pull, and I ask my assistant to pull the leg. The fracture does not come to the right position.
You try to mobilize first.
Yeah, I try every method.
Okay.
This is my problem
Ready to operate today?
today.
Because yes, we can try. Okay, so the other problem is very obese persons. Sorry, it's okay. If they have the abdomen full of gas in the supine position, it's a nightmare to see the safe corridor. So in this, because the abdominal gas is everywhere, so you need to mobilize with your hand the abdominal mass in order to allow the gases to be in some other place. So you mobilize the bowel, the bowel like this, and you check if you can clean from the radiological point of view the corridor. If you are not able, you put the patient prone. Several times by putting the patient prone, just the weight of the body is changing the position of the gas of the bowel. And if doing this, you cannot see, this is the 11th commitment. You shall not operate, not a screw. You need to open the back and put a plate. Okay.
So at that time, I change the position and open over the SI element and find the hole. You have a triangular I put a clamp in and traction, and it much easier. And put the screw in there. Also the tension band plate. Double.
Okay, so if you have an open approach in the back, now it's much easier to position your. Do we have a plastic model here? Okay. When you are working supine, you have.
Yeah, no.
Awaken the patient, please. When you are. Thank you very much.
Thank you.
When you are working in the supine position, you have no anatomical landmark. And this is a problem. I think you can hear. If you are working supine, if you are walking supine, you have no anatomical landmarks. But if you are walking prone and you open here, for me was easier at that time because I used to put my finger in between L5 and S1, and then I palpate here, S1. I have this already open, so by using my finger here, I was able to find a safe corridor by palpation outside. I checked the trajectory, and then I was able to aim my drill bit with the assistance of the C-arm control. And if your SI joint is well reduced, you can palpate, you can put the finger anteriorly also, and then you can aim because you put the finger, you palpate SI joint space. If your finger is long enough, which is not my case, you can even palpate L5 root from the behind, and then you know where not to go. You put the second finger here to hold, and then you develop an ME device with the left hand, if you're right-handed, and then you can put the drill bit pushing, and when you feel that you are exiting the bone, this is the moment you need to start to have trouble. But if you don't exit the bone, you have to find a safe corridor manually. Letourneau used to do that without the C-arm. And he was drilling and say, 40, 60. That was measuring with the because he knew beforehand, which is the drilling part of your drill bit, which is the length. You have a drill bit. It has a smooth part and it has a drilling part, which is with a spiral, which is the length. Did you measure it? No, it's very rare that we measure this part of the drill bit. But if we know the distance from the tip until the smooth part, usually it's around 42 millimeters, and you are drilling and you know that you did put half of the drill bit inside, you remove it, and you know the length of your screw. It's very easy. You need to know, you have to know your instruments, the size, the diameter, the length, then your life is going to be much more easier. Okay. So now surgery.
Okay. You want to discuss the treatment of this?
No,
Surgery.
he is the surgeon.
Oh.
He needs to condemn some of his crew members.
Former fellow.
Did you approve him?
Okay. I think I will go to the front supine position and
Fine position, okay.
And
Are
I think
you afraid of this mass of gas here and here?
maybe I will
Are you afraid?
a little bit, and I will try to take the fluoroscope first before the preparation.
No, but you are looking this. Suppose this is the fluoro. Is it creating any trouble for you? Could you see S1 foramen?
No.
This is a problem sometimes, but now you can see where this is S1. So my suggestion, when I cannot see the fracture side, and it is clear for me the uninjured side, take a look and I try to imagine where my drill bit is going to be in the uninjured side. This is the last chance you are going to take without changing your strategy. But in this case, I can see the S1 foramen. It's very clear. You know, with the years, you are going to see what someone else is not able to see. This is a clear situation that's coming with experience. and you are going to be taking much more risk. But this is true until you reach the age of 60s. After 60s, you start to decline. You assume you are going the correct zone and going to be taking risk because you think that your experience is going to help you, but because you don't see so nicely, you are in a risky situation. So double check. If you cannot see, you have to think, you have to analyze, and your hand should be working according to the rational way you did develop your strategy. It's not only I can see, so I can do. You have to combine what you can see, what you understand. So understanding is much more important than seeing. Because you can see because you are young, but probably you cannot understand. So you have to combine being able and the understanding of the problem. Okay, so please.
Okay, so I think I try the protocol first before the preparation, and if I can see the corridor, I will go to the supine position. And I think maybe the SI joint is hard to close direction. I think maybe I want to open direction via the lateral window, and I may reduce the posterior first, I think, and use the supinacetal pin or the far above to hold the ilium to redirection the SI joint. And if I can reduce it, I will temporarily with the KY, or if the KY cannot maintain the SI joint, maybe I can use the screw to the both sides of the SI joint and use some far above or jumbo clamp to hold it and put the transaxle screw for the two screw, maybe S1 and S2, if there is no sacral dysmorphism. And then if the posterior is finished, so I will pick the anterior with the, I think maybe the screw is cannot purchase because it's very medial side, so I will put the plate.
Okay. Okay. Any concern about the fracture right now with the CT? With the X-ray?
Yes.
Where do you have instability here? Here, 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 and here. And because it seems that you have instability not only here, but also here and here also. Okay, it's quite unstable, isn't it? So with the time, it's going to be displaced. So any different idea about how to fix it? Sorry, how to fix it right now after taking a look to the CT scan? Are you going to use a plate or a screw in the front? What about the back? Screw in the back? Do you think that the S1 body is partially migrated into the pelvis? Because of the viewing, or is just because the sacropractical dislocation is posteriorly migrated, which is almost to say the same. If one is going back, it's because the other one is going anteriorly or forward. So any clue how to reduce it after the pelvic course in Chiang Mai?
I think for this one, I would want to do the posterior approach in prone position to reduce the. So I think if we want to talk about the displacement, so I would say the sacrum is like a proximal part. So we say that the right sacrum is posteriorly displaced, and then so I think that the on the left side they may not need reduction, but on the right side definitely. So I would do the open reduction of the right sacrum, and then because this is like a spinal pelvic dissociation also.
I see. Good definition. This is what I wanted from you.
So in this case, I would probably do one iliac transarcal screw after open reduction on the right side, and then put the lumbopelvic fixation on the back. With that said, after reduction of the back, so we flip the patient to supine position, and usually the right side should it should reduce a little bit on the anterior. And if it is possible, then I would do through screw, the retrograde screw on both sides.
Okay. Let's see what happens here. Next. This is not working all the time. Okay. This is what we have done. Supine position. We reduce everything supine. Percutaneous screw in the back. And then when we finish, we put the patient prone and made a spinal pelvic instrumentation. So if I tried several times to do the close reduction of the supine position, if I success, I fix it. And then I neutralize with the spinal pelvic instrumentation. In this case, because it's a bilateral lesion, and it is a kind of H fracture of the sacrum or spinal pelvic dissociation, I use bilateral fixation in the back. In case I don't have the spinal pelvic instrumentation that happened to me before, I did use just screws or maybe a screw with a plate. If there is very bad soft tissue in the back, it's going to be just a screw fixation. Close reduction, percutaneous fixation with a screw. And I'm going to use the longest possible screw available. But however, if what happened in my country, they are not such a long screw, what I'm going to use is I'm going to use screws one side, screw the other side. I'm going to inter-engage the thread of the screw one side to the other in order to increase stability. I'm going to put several screws inter-engaged. So by doing that, my strongest part is the midline, that is the body of S1. And if you take a look, the screws are not interconnecting, but they are very close, so the threads are touching each other. So I do this especially in all individuals. Okay. I think that's okay. This is the next case. This is just to think about because we have a wonderful coffee break.
Yes. So I think how many minutes? 5 minutes.
5 minutes?
No, 10 minutes. I think we have and then but you can take the coffee break and the coffee inside to have it. So we have 10-minute break. Okay. Thank you.
The opposite.
Okay. So we have now this beautiful case with the financial support of Simbom, Who wants to be the surgeon? It's an easy case, isn't it? No, 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 don't go. Okay. Okay, so we have an AP view and we have to recognize everything in the AP view. It is said that if you have an AP view, you can recognize in an unstable pelvic fracture almost everything in more than 90% of the cases. So, do we have any volunteer? Someone drinking an orange drink?
He's an expert from the eastern part.
It's part of
Yeah.
Thailand.
In this case, I see the fracture in the sacrum comminution and in the fracture forami, and it has a superior migration of the wrist and is unstable, and I think it's combined type.
So if we practice this systematically approach of recognition of the places of instability, the pelvis is okay. There is a fracture here, no here, no here, no here, at least not in the X-ray. I don't know what's happening here. For sure, there is a fracture here, no fracture here, and there is a fracture here. And this is cranially migrated, isn't it? Okay. And what is this? It's a pelvic sheet, the whole sheet. Okay, so she was hemodynamically unstable, and that was the attempt to stabilize the pelvic with the sheet. Do you think, are we going to succeed in stabilizing the pelvic using a piece of cotton? Why not?
Because it's just temporary. If it's just temporary in much more simple case, yes. But in this case, we have rotational instability and also the vertical instability. Also, that we can see the hemipelvis of the right side going up. So if we were to combine the temporary mean to stabilize the fracture in this case, maybe we should add a little the distal femoral traction on the right side also.
Okay.
But they're just temporary.
And what about the diameter of the pelvis? Is it smaller? It's equal as it used to be? It's bigger?
The diameter, right? If this X-rays through AP, which we can see the spinous process and pedicle on a spine, which is quite AP. We can see that aside from superiorly migrated right hemipelvis, the right hemipelvis is also internally rotated.
Okay, so that means that if you
put the binder is increased
too much,
yes,
you're going to
increase the
finalize with the secondary deformity, which is an internal rotation of the already fractured hemipelvis. So this is okay for the first hours, but should be changed to something much more effective in terms of the shape of the pelvis.
Yeah.
Okay. So do you need some other information?
Yeah, to complete the evaluation, we
Please,
should
Rahut.
I'll let.
Okay, so it is clear that the midline is displaced in a certain amount of displacement. It's not such a big, because this is internally rotated, this is posteriorly migrated. Maybe it has something here also, I don't know. Maybe. Okay. Enough information. Let's go to the much more sophisticated. What do we have? Okay. And it's a good case for retrograde screwing. You have to think about the percutaneous screwing of the fracture in the front. So you have the oblique views, the foramen obturator oblique view. Okay. Anything more? Do you need much more information?
Yeah.
Okay.
CT would be nice.
CT, because we have money to buy a CT scan. And this fracture that was seen in the inlet view is here. We have this fracture here also.
Yeah.
Okay. It's an H-shaped fracture of the sacrum. Stable or unstable?
Very unstable.
Okay. How do you treat this fracture here in Bangkok? Because I'm going to remain at least tomorrow morning, so I want to know if I'm safe or not.
Okay.
Just in case, I'm not very good in crossing the street because the cars here, they are coming from the right. At home, they are coming from the left. And always I get confused.
Yeah. So I think this case is from the fracture pattern without CT, we already guess that it's quite unstable already. And with CT, we also see the fracture on the
Do you
sagittal
really
line.
need the CT to recognize that it's an unstable fracture?
No, in this case
Okay.
not, but it gives us more information on the left side that also has an injury as well. So we need to address that. Luckily, it's not that displaced on the left side.
Yeah, so
And-
you went to see the CT not to be surprised by the image because you wanted to confirm your suspicion by the plain films.
Yes, of course. And also I see that there's some contrast in the bladder. So I think this case, the rami on the right is quite dangerous to the bladder as well. I think in this case, maybe there's clinical hematuria already. So they send this cystogram or something.
She has no puncture of the bladder and she is doing okay, but this is nice to see that this fracture mechanism or fracture pattern or a vertical shear converted in a lateral compression because of the binder could damage the bladder. So do not stretch too much the binder without taking care of potential complications. If you puncture the bladder, and this is just a puncture, and you have a Foley catheter, nothing is going to happen. The treatment is leave the Foley catheter for 3 weeks and it's going to heal. But a real rupture of the bladder could be a different kind of animal. Okay. More information about the comminution of the sacrum. And are you ready to do surgery?
Yes, do surgery, of course, but I would like more information about the
More information.
about the neurovascular status of the S1 and S2. So because there's
The patient is intubated because she is a suicide jumper. Sorry. And she have a comminuted fracture of the pilon ipsilateral. Oh, it's okay. we have done is try to make growth reduction. Again, I'm going to show you step by step growth reduction of such a fracture. So we take a look at the front, and now we have a view of the back. And do you remember how was badly displaced? If you attempt to close reduction when the patient arrives, you can fix it the same day. And this is step by step how to fix it. So this is my drill bit. It looks, in fact, it looks like a drill bit, but it's not a drill bit. It's a reduction tool. I put the drill bit in S1 and I leave it in place. Now it's holding the reduction. I'm not going to drill and try to find the hole with a K wire or whatever. No, no. My drill bit is going to be holding the reduction. So my assistant is not going to be pulling as strongly, and it's not going to be moving back and forward or up, down, or downward. So now is the moment to check again. This is a moment for the cannulated screw. So second drill bit is the first one is a reduction tool. The second is for the screw fixation. Then I change one drill bit for the other. I tried retrograde screwing. I thought I was able to do it, but I failed. Sorry, shit happens. So I decided to open and do a formal internal fixation with a plate. And you can see this screw that's going anteriorly into the limit of the acetabulum, where it has very nice bone perches. You can see the screw. Or at least the drill bit. Then we finished fixing the opposite side because we wanted to be sure that the mild displaced fracture was going to remain in place. And you take a careful look, the threads of both screws of the screw of both sides, they are engaged. Could you see? Now she can be seated, but she is unconscious. Sorry. This is a procedure that has no sense. Are you happy with the resolution? Is there anything more that can be done? Nothing more? Just wait and see if she's going to be awake. Any concern? Comments? I'm waiting for your comments.
Okay, so I would like to ask something. So you would try to close reduction on the supine in every case first, right? Because at the first glance, I saw the fracture is quite like unstable and displaced. So so it's quite astonishing that you can achieve this reduction and hold it until the fixation was in. So how do you hold the vertical shearing component so that the fracture is in place so you can place the screw? You put the traction.
I put the patient in traction. Once it was reduced, I put with my hand and a hammer, the drill bit, the first one, and I leave the drill bit in place.
So that act as temporary stabilization for you?
Yes, this is a 4.5 drill bit. It's much more stronger than any K wire, and it's holding in place the reduction. So by doing that, the second drill bit for the screw is going to be very easily positioned because you don't need to move. One of the problems is you do your perforation, and then the assistant is loosening the traction. So the hole now is here, now is there, now it's anterior, now it's posterior. No. You put the drill bit in place, you say the assistant, usually it's a resident. and he wants to collaborate, chatting with the scrubbing nurse. So for that reason, my first assistant is a drill bit. The drill bit is going to remain in place. It's not going to chat with anyone. It's not going to be complaining, and it's extremely accurate. And then I continue with the second drill bit for the screw fixation. As soon as I have two screws over there, I don't care what the resident is going to do. If he needs to leave the hospital because he has a football game, it's his problem. I have already resolved mine. So use conventional tools to develop sophisticated reduction devices. So remember, it is supposed that we are coming from Africa, Homo sapiens, sapiens. But in fact, Homo sapiens sapiens is the most elevated condition of the human being. Internist, psychiatrists. We orthopedic surgeons, we are a little bit much more limited. 1, 2, or 3 level lower, Homo habilis, the man who makes, Homo faber. So you have to be ready to develop your own implants or instruments while you are doing surgery. Remember Homo habilis, and previously our very close relative, the chimpanzee, they were using a stick to move a banana. So it is the same for us. Be ready to use the stick to fix the pelvis. But because I wasn't able to put a retrograde screw, I changed my mind for a plate. So be ready to change your mind. If you cannot, don't destroy everything. And this is damage control orthopedics. Because with 2 screws in the back one side, 1 in the other, I was able to fix a pelvis in very unstable situation in someone who was really hemodynamically unstable. So I don't need to waste time trying to put retrograde screw. 1 attempt, 2 attempts. If I fail, I open and put a plate. Perfect. Now she is stable from the mechanical point of view and from the hemodynamical point of view. And I put an X fix for the severe comminuted pilon fracture. And I sent her to an intensive care unit because she was not going to be seated because she is unconscious. 2 days later, her general condition did improve, still intubated and ventilated, and I decided to do something more. I put her prone, and I have done spinopelvic fixation. Okay? Now I'm sure that she can be ventilated in the prone position because I have done surgery prone. She can be mobilized laterally. She can go everywhere. Now she's able to walk. And look, sometimes your colleagues could be your enemy. Fortunately for me, because this is contrast media in the bowels, several times this contrast media is in a given position you cannot see. And if you cannot see, you shall not operate. Okay, let's go. Rahut, please. So this is the resolution, which is not perfect. There is remaining of anterior displacement of S1 body, but it also be possible to happen if you put it prone, because this kind of fractures several times they are engaged, and the only way to reduce it is by open reduction and manipulating with 2 lever arm. And I think it's sometimes too much because several times there is no neurological damage at all. Go ahead, please. Head. Once more. This is sometime later. Okay. You can see the position of the implants again. Once more, please. Once more. Sorry, it's remained the Spanish version. This is 1 month after the surgery. Once more. 5 months after the surgery. It's already healed. Once more. Once more. 6 months. Everything was removed. Now she can move the lumbar spine. This, at least in this moment, for us, is a standard of care. As soon as the sacral fracture is already healed, we remove the spinopelvic instrumentation. I think this is enough for this presentation, and we can go to, now you know how we do think. Now we are going to, I want to show you first all these acute cases to demonstrate you how we do think, and we try to fix some unstable pelvic fractures. Now we are going to the main course, the deformity. And I'm going to show you different cases with different kind of deformity. And I try to show you how to analyze the deformity and maybe how to correct it. So, who wants to, he is coming to your place. She is medical student. Now she is around 24 years old. At the age of 8, she suffered a car accident. And who wants to guess her complaints? Just watching the AP. Yes, go ahead. You're a good answer.
I think I think she will have a problem about imbalance when sitting, or a low back pain, or imbalance when walking too. Maybe I think due to the different position of the iliac wing and the hip level too.
Okay, so but she is standing and the hip levels are more or less at the same height, isn't it? Or she's resting supine. But if you take a careful look, because the previous orthopedic surgeon told her that she has nothing important. Do you believe that she has nothing important? Because you guessed that she has limping, sitting imbalance, and something more. So you have you ruined my presentation. Okay. But this is absolutely right. But I'm going to tell you how to recognize that. Is this better or worse? Which image is telling you more, the CT or the plain X-ray? You have done a good job with the X-ray. Can you tell me the same with the CT?
I see more information because this is the malunion of the left sacrum fracture before, and
The problem with the CT is the radiologist printed what he thought it was important. Yeah, but not necessarily it's important for us. But you have done a very good description from the plain X-ray, but we need to improve the quality of the description of the plain X-ray. So forget about this for a moment. Let's go next. This is the plain X-ray, and you can see 3 red lines, okay? Very simple. You can manufacture a sophisticated device with 3 red lines. Next, please. 1 is vertical. And then you can tell me what's happening with the lumbar spine. Is well aligned or not? No, this is supine. Is the lumbar spine well aligned or not?
it's not aligned.
Not well aligned.
Yes, it's asymmetrical of the both pelvis. You can see my scoliosis of the lower spine
Okay.
connect to the sacrum,
Okay.
and tilt of the sacrum, and tilt of the anterior ring of the pelvis too.
Okay. So next, please. Now, what about the height of the ischial tuberosity? Are both height exactly the same?
I think it's maybe because of the flexion extension of the hemipelvis that you can see the inappropriate of both obturator foramen.
Okay, so what you are telling me is that one hemipelvis is migrated into the opposite side. For that reason, the pelvis symphysis is not well aligned with the red vertical line. Please, next. And you can see, quite interesting, the height, this hemipelvis is higher than the other, and this ischial tuberosity is lower than the other.
I
Okay.
think it's
But something is missing. Do you want to have a little bit of help?
yes, I'm here.
Please, next.
มันมีอะไรหาย
Rotate the picture.
มันช็อต
Next.
มันช็อตที่นี่
And now, this is the real situation of the patient. When you put vertical the lumbar spine and you change the X-ray delivered by the radiologist and you correct the deformity, this is the real situation of the patient. She has this hemipelvis higher than the other. It is internally rotated. This is the first vertebra, sacral vertebra. And now, with 3 red lines and 1 yellow, you have a precise diagnosis of the deformity, which is exactly from the clinical point of view, what you have said. She came limping, when sitting in balance, and low back pain. And low back pain was related with the deformity created by the displacement of the pelvis, because she's coming from the northern part of my country, and someone over there offered her a femoral lengthening to compensate the deformity. Can we go further? Next, please. So you can see the difference with and without correction. It's very simple. You can do it with your computer. You don't need a CT scan, because the CT scan, 3-dimensional CT scan I did show you, gave no information at all. You don't know exactly what's going on. Please, Rahut, continue. Now the same situation with the outlet view. Again, please rotate. Now it is much closer to reality, because when she tried to put straight the lumbar spine, it was like this. When she was putting both feet at the same time, it was like this. So this is the reason of the low back pain. Rahut, please. Again, please, once more. The problem is not only the displacement. You can see how is positioned the hip joint in one side and the other, because she suffered a pelvic fracture at the age of 8. It's not only the displacement, it's the arrest of the growing of the hemipelvis. And for that reason, sometimes the end result is one hemipelvis is smaller than the other. And surgeon can mobilize one hemipelvis in relation to the other, but it's much more difficult to make it bigger, to make it grow as its original shape. So for sure, if you have one hip anterior and one hip posterior, you are going to be moving like this. This hemipelvis is going to be forward because you want to have both hip joint at the same level. Forward like this, and she was walking like this. Okay, next please. And then you have here, it's not a clear scene, but relatively longer right side. So now she's standing. You can see the lumbar spine, the lateral view, scanogram. Next, please. This is how to analyze the deformity. Next, please. And we want to know how is she while she's sitting, because she was complaining while walking and while sitting, as you said. So this is the sitting imbalance projection. This is a normal person. Next, please. And this is the sitting imbalance projection of this lady. While she's sitting, both ischial tuberosities are touching the table, the exam table, and you can see the lumbar spine, how is deformed. So the so-called scoliosis they wanted to treat is clearly seen here. Next, please. Next, please. So if you put the vertical line that goes to the spine here, and horizontal line, both ischial tuberosities, and the yellow line is the line of the first sacral body, and the blue line is the symphysis pubis. Next, please. So in this diagram, you can see the difference between a normal person and our patient. Okay, next, please. And now with a lift, to compensate the difference in height of one ischial tuberosity and the other. So could you show me where is the scoliosis? Because when we say the scoliosis, it should have a rotational component. And if it has a rotational component, both pedicles of each vertebra is going to be in a different position when you are moving from one level to the other. They are going to be rotating. And if I take a look here, pedicle, 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 they are in line. So there is no rotational deformity. So they offer her to correct the leg length discrepancy and to treat the scoliosis by surgical means, because she was approached by an orthopedic surgeon who performed lower extremity surgery, and she was approached by a spinal surgeon. So those who have a hammer in their hands only find something to be hammered. So everything looks like a nail. But this is a different kind of animal. The problem is not in the lower leg, the problem is not in the lumbar spine, the problem is in between, which is the pelvis. So she is addressing for someone who pelvis experience. Okay, next, please. Next. Next. Again, the correction, the lift. So what to do? Who wants to be the surgeon? You, young lady, you have done a good job with the plain X-ray. That's the problem. You didn't spoil my case. You ruin it. Someone from this side of the audience? Rahut, condemn one, please.
This is a difficult.
Or maybe you. So that's the reason why you need to condemn.
Yes, yes. Maybe. We have Dr. Sukani.
So I'm very impressed about this case first. So honestly, I have no experience with this deformity, but this very clear that you show us about pelvic deformity that is caused a problem of this patient. So I think it's very difficult because development of this patient is the trauma is occur at 8 years old, right? So the pelvic anatomy is deformed also, so that is very difficult to get back into its position. But in my point of view, I think what we can do is the lengthening of the right hemipelvis to correct the deformity. That is the first one, limb length discrepancy. And about the sitting imbalance, it might help a little bit, I think. But for the rotational deformity, that may affect the scoliosis. I think that should be done. But I'm not sure that do we have any supplement, not only the osteotomy and fixation. I'm not sure.
Okay.
Thank you.
So from the conceptual point of view, if you have deformity in both sides of the pelvis, you need to correct both sides. And suppose one side is elevated, you need to correct this elevation and mobilize down. Suppose the other side is wide externally rotated, you have to internally rotate. This is, generally speaking, how it should be conceived, the treatment. Then we are going to get into the details, how to mobilize one hemipelvis and how to mobilize the other. So please, Rahut, if you are so kind. So we did start performing the posterior release. We wanted to release the posterior hemipelvis. This is the flap. The arrows is showing the gluteus maximus flap, which according to the drawing you have in the front and on the right. Next, please. Next. And then we perform a release in the front, the percutaneous release of the symphysis pubis. Next. Then excuse me, the release in the pubis was done first in the supine, then we put the patient prone. We have done the soft tissue release, and now we are performing the osteotomy in the back. And the drill bit is guiding my osteotomy in order to be sure the angle. Next. This is the osteotomy. It is part of the osteotomy is into the pelvis. So at a given moment, I replace it for something which is, I have a chisel or osteotomy up on top. Over there, it's not, it has no edge. After cutting with the osteotomy here, I replace this. This is round here. This is blunt. So it's breaking but not cutting in order to avoid the damage of the important structures. Next, please. Then I ended with the release anteriorly and posteriorly. And I put her in skeletal traction. Next, please. And then I pulling, next. And then, see, now it is a little bit much better, but still it's missing correction. Next, please. Next. So I decided to go to the opposite side for the correction of the other hemipelvis. And you can see here the osteotomy that was done from the iliac crest into the greatest sciatic notch, almost percutaneous. You have a small approach. I know that I had some problems. Next, please. I open it. Again, next. Now I'm trying to figure out how is the midline. Next. Next. This is a reduction of the midline. Next. The fixation of the osteotomy. The fixation with the screw first and then the plate. And then the fixation of the previous osteotomy. Next. And you can see, because the osteotomy, my osteotomy was very lateral, similar to the crescent fracture. I'm not so sure. I was chatting during the pelvic course that I use, when it's a crescent fracture, I use a 3-hole 4.5 recon plate as if it were a big washer. So my screw is not going to be into the fracture line or the osteotomy line. Then I'm fixing through it. Next. And you can put 3 screws through this plate. And you can see the screws are up, middle, and down, but they are converging in S1 body. There's plenty of room for 3 screws and even more. You can put the screw at a different level. Next, please. And we finish like this. I wanted to finish the case with the patient supine. That was Friday afternoon. The anesthesiologist was a little bit upset because he needed to go to some other place. He said, no, you cannot continue. Okay, no problem. It is okay for me. It's not perfect situation, but it's much better at the very beginning, because I wanted to create a posterior fixation in addition to the screw. But I didn't schedule the case for Monday, so I have the weekend to take pictures. Next. This is the correction we found. Next. And next. It's not so bad. Next. Please, next. And if you take a careful look, it is much better, but still is not perfect. Something is missing. It's a pity. Okay, but provided I was going to finish my case on Monday, I decided not to be worried. Took my CT. You can see the distribution of the screws. Next. And this is Monday afternoon. So I removed those screws. I put a plate. This is a nice trick. I put this plate in the border of the sacrum, then in the border of the ilium. So I use it as a reduction tool in order to improve the displacement of my osteotomy. And then I put a second plate to neutralize and refix. So first removal of the cannulated screw, then using the plate as a reduction tool, the other plate crossing the fracture line as creating much more stability, and the screw again. Please, next. Now I have the impression that I was able to correct a little bit more. Next. Next. Yes, it looks much nicer. But it was originally my plan. So what I have done on Friday afternoon is damage control. The anesthesiologist said, okay, hurry up, we are in a trouble. So damage control with the screw. And then I finished next Monday afternoon. I put the patient prone. I took several times to resolve this. This is, look, the position of both femoral heads. They are much more closer to the normal. Next. Next. But still there is minimal residual displacement, or maximal if you are a perfectionist. But it was impossible to me to recreate the length, the whole length of the pelvis because of the gross arrest. But this is much better. So full weight bearing and 4 months of follow-up, still there is an amount of deformity because patient usually takes longer time to accommodate the muscles to balance properly the lumbar spine. Next. 5-month follow-up. Next. Next. Sitting imbalance is corrected, so the problem is in the lower extremity. So how is she? 1 year of follow-up. Everything was healed. Conclusion, this is a difficult surgery, training very demanding, adequate results are expectable, and mechanical problems and solutions should be found. Questions, comments? Something different in your hands? Yes, sir.
Excuse me.
I cannot hear you properly. Please. Yes.
I have one question about after you do the osteotomy, there's looks like there will be a bone gaps, right? So do you put any bone graft, or what kind of bone graft do you put, or nothing at all?
No, no bone graft, not from any other place, like only pelvic material. So when you are in the back, you can harvest a little bit of bone graft from the posterior aspect of the iliac crest if you need it, but if the fracture, the osteotomy is under compression, it's going to heal. You can see in the inlet view, the left side, it has full contact at the pelvic ring, but no contact at the iliac crest. It is exactly what happened with the periacetabular osteotomy. It is started to heal from the deepest part into the surface. As soon as it did heal, let's say 30 or 40%, you don't worry what's going to happen. It's like the iliac crest is like bone harvesting. When you have a bone block, it has a defect that is contained by the screw and the plate. And everything did heal without bone graft. At least no bone graft from some other place.
Thank you.
I have one question. So you taught us very well about the analysis of the deformity with all the very good X-ray. But the problem for me, for example, if I have to do the osteotomy, is that intraoperatively, right? For example, when you do the osteotomy on the left side, I want to go back to that picture.
No, you have it over there.
Okay, this one. And so I understand that the principle is to create instability and reposition and fix again, right? But my problem is when I do these cases, for example, if I want to do this osteotomy and I'm correcting the deformity, intraoperatively, it's very difficult to know how much to distract, and because you need very good X-ray to reposition, to analyze the deformity. But intraoperatively, this is very difficult to judge how much you would distract or something like that. How do you, Yes. Yeah.
The problem is that, sorry, I'm sitting, but my legs are a little bit problematic getting older. I cannot be standing longer than 4 hours. The problem is that you don't have the whole film. When you have a picture of it's in the classical way, it was 43 by 35 millimeters. And when you have the spot, the C-arm is 20 centimeters. So this is a smaller spot. So you need to rationalize how to correct the deformity in a limited environment. So you go back and forward, you neutralize the lumbar spine, you check, okay, my lumbar spine. So the radiologist should be fully trained to understand what do you need. So you analyze, my lumbar spine is perfectly aligned, go proximally, and then do not move the C-arm always in the same degree of rotation, then move it into the distally, go back proximally. So you check the position of the midline and the position of the pubis body back and forth. And look, I think I am very close. That's okay. The other issue is how to recognize that you have corrected the cranial migration, because you cannot see at the same time the ischial tuberosity and the iliac crest. So that's the reason you have to understand very nicely this plain X-rays. When you have a plain X-ray in the outlet view and you have a cranial migration of the right hemipelvis, like the case that was a suicide jumper. Did you remember how was the position of the fracture of the sacrum? Was anterior or posterior? It was in the outlet view, it was superior. And in the inlet view, it was anterior or posterior? Posterior. Always, when you have a cranial migration, in the outlet view, it is posteriorly migrating in the inlet view. Even though you don't see the whole X-ray, if you check the position of the hemipelvis and you did correct the hemipelvis anteroposteriorly, in the inlet view, you did correct the hemipelvis caudal cranially in the outlet view, and this is the trick. So if you have such a displacement anteroposterior, and then you finish with this displacement in the inlet view, both pubis symphysis at the same level, for sure the SI joint is going to be almost perfectly reduced. Otherwise, it's quite impossible. And these are the tricks. There are some other tricks you can develop. You put the wire of the electrocautery to align with the lumbar spine, and then you follow. But it's not always perfect. I did use like a cross, 2 bars of the X-fix. And then I was moving, rotating with a 2-2 clamp in order to have alignment to the lumbar spine and the horizontal to the ischial tuberosity. Sometimes it helps. And several times you need to combine small details in order to understand where you are going to be. And finally, you can get surprised by the X-ray because you think, I have done a good job in the film, in the field, but the postoperative film is showing you that something is missing. It takes time to understand all these tiny details, but with practice, you can arrive very easily to the understanding of the solution. Questions?
I would like to ask about the technique that you get the length, especially when we have a pelvic injury, vertical shear type, is migrate superiorly, right? And technique of the traction intraoperatively, or in this case, I think it might be very difficult because the soft tissue is still intact.
It's a good question. In acute case, you can put the patient on the traction and it's very easy to reduce. In such a case, you perform the open approach and you release the ligaments from the sacrum. Once you release everything from the sacrum, that means sacrotuberous and sacrospinal ligaments, and all the retention of the hemipelvis is going to be decreasing. And I put the patient in a skeletal traction for a while to check if it's correcting gradually with the weight in order to protect the roots. With this lady, after the first procedure, she was moving the foot, no problem at all. After the second procedure on Monday, she wake up with a drop foot. Maybe I did create too much traction with my clamps, and she was with a drop foot for the first year after the osteotomy. I decided to do a tendon transfer from posterior tibialis into anterior tibialis. Did work for a while, nicely. In the second year, she did recover the original function. I mean, I didn't cut the root. It just was a stretch. I do prefer to do the transfer very early because she's going to have much better function. And if she recovers, well, we call it in Spanish super transfer or augmentation, because the recovery is not always exactly the same quality of strength as it used to be before, but still is much better than having a drop foot. So you have to expect sometimes complication, and you have to be trained not only to make the bone osteotomy, but also the soft tissue repair, or even the soft tissue is the transfer of the tendon. This is the job of the pelvic surgeon, not the plastic surgeon or the foot surgeon or whatever. You made the mistake, you have to solve it. More questions? I have another case. It's a late presentation. And I think it's a little bit different way to think.
Excuse me, Carlos.
Yes.
I was wondering about the osteotomy on the anterior side of the ring. You cut in the middle of the symphysis, right?
Yeah.
I would like to know, so if you cut in the symphysis, it's like a ligamentous healing, right?
Yeah.
So do we have any other choice to get the bone-to-bone healing, or is it okay for it to be like ligamentous healing for the deformity correction?
It depends on your case. You can release the symphysis, so you can you can release the symphysis. You can make an adjustment of the pelvis line, or you can adjust of the ram. You cut where you need to be cut. The only problem with the symphysis is that if you go very deep, you can damage urethra, because urethra is immediately here. But do you have any friend who practices neurosurgery? They have much difficult things to do in the middle of the brain. So it's a matter of training. Okay. Okay, let's go. So the problem is here. Next, please. Who wants to be the surgeon? Young lady? No? You can cry, no problem. Someone else? No one? Look, tomorrow my flight is at 10:30. I'm going to Tokyo. I need to finish today with all the cases. So please hurry up.
Yes. Who's going to be the lucky one? Maybe Dr. Nachapan. Lucky one, you. Please help. What do you want to do in this case?
You have no idea, you can set the case to Rahut. Because I'm sure he wants to be involved. Where is the problem? First picture, the problem is here.
I think the problem is at the right side. It has some proximal migration and medial translation of the pelvis, and maybe rotation, internal rotation. So First of all, I would like to discuss to the patient that are there any problem and the plan, the list and benefit for the treatment, like the osteotomy or the correction. If the
Do you
patient,
have any other treatment different in a pelvic osteotomy?
I think at this time I no idea other than the osteotomy.
So because for sure, look, the lumbar spine is straight. One hemipelvis is higher than the other, but one hip is higher than the other, isn't it? So in order to walk, she can help us. How is she? Please come here. Because the patient is a lady and you can walk as a lady. Show me how is she walking. Because if you can imagine the patient, you can imagine how to resolve it. Do it, do it. This is, you know, this technique is called role playing. Yeah, and do you think this is comfortable? Can you use nice trousers? No, or a nice shirt? Skirt? No. High heel shoes, maybe they are going to help because females, they are using high heel shoes. How high should be the shoe? How many centimeters? 2, 3? If you, she's a lady. If you were the patient, are you going to request a surgical procedure or a conservative one? Ask your colleague. He is the doctor, you are the patient. Surgery, you know that this is like Hamlet, Shakespeare. To do, to operate or not to operate? That is the question.
No.
But do you like to be operated? Because usually the patient, they are knocking the door of the surgeon requesting the surgery. You as a surgeon just interpret the desire of the patient. If the patient comes to your office and said, look, I have this problem, but I don't want to be operated on. You said, look, it was my pleasure. Go to someone else. Because I have nothing to offer you. But if the patient is knocking your door and you are a surgeon, look, in my country, surgeons are like lions. Do you know any lion that eats grass? No, we eat meat at home, a lot of meat. So surgeon is a lion that eats meat. Meat means blood and flesh. That means surgery. So she was telling you that she's limping and you need to offer her something. You don't want to operate? Fine, because this is a problem sometimes. So take a phone, say, Rahut.
Yes.
I have no clue how to do it, but I'm sure she needs some help.
Yes.
Yeah?
I do like that.
Discuss the case with him, describe the problem. Rahut is in the phone. So we need the help. Okay. Next. Next. Okay, so this is more or less the deformity. Next. Again, now we are going to analyze where is the instability, or at least what it used to be, because probably right now is stable. However, if it was unstable in a given place, and now it's stable, what does it mean? It's telling you where you need to perform the osteotomy. That's the reason we didn't spend the very boring first lecture about the spectrum of instability. You have to understand where was the instability from the very beginning. If you cannot analyze the instability on acute basis, you cannot correct late presentation. So again, Rahut, please. Next, 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 next. Again and again. So plenty of images. Next. Now, sitting in balanced condition, leg length discrepancy, the correction of the deformity with a lift. She had, just to make your life a little bit much more complicated, bilateral tibia fracture, one heel shorter than the other. So this is increasing the deformity while she's standing. You were right, young lady. She was walking miserably. Again, so pre-op planning, where and how to correct this. We need a surgeon. No surgeons? Internist? Psychiatrist? Maybe psychiatrist is okay. So do not attempt to be operated on. Those surgeons are crazy people. They try to release their aggressiveness, cutting people in pieces.
It's okay. Can I try?
Yes, because everyone was sending the patient to you.
So I think first we have to create the instability. So maybe for me in this case would be, I will go the posterior. I will go to the SI joint because I think maybe the easiest for me.
Can I interrupt you?
Yes.
This is round, isn't it? And this is straight. One of the problems when you have a late presentation is because of the displacement, the fracture or fractures close to the acetabulum change the shape of the anterior column. After the migration, they straight the fracture and they heal in a straight position. Sometimes it should be corrected. Some others you can accept, or you know the concept of the cora? So the cora is a concept that applies everywhere, center of rotation and deformity, or an angulation. So sometimes for articular reasons, you don't want to correct the cora at the level of the hip joint, or sometimes you need to correct the cora at the hip joint because the hip joint it is involved and should be corrected. So take into consideration, and then I'm going to show the mistakes I made in this case that fortunately I was able to understand for future cases, because case by case, you are learning from your patient. So, no, you have to be. No. Now you are the surgeon. I am challenging you. So these are the different problems of this patient. So Rahut.
Yes. So
what are you going to do?
So I think, like I said, I think posterior, I go to the SI joint, and then the most reasonable thing to do is osteotomize at the angle of the cora, right? So that's the middle arrow in the front, and then yeah. So the other part is that I'm not sure if the pubic rami is also another thing. And then after we do the mobilized and also the ligaments, maybe we have to release the ligament too. So we have to, so I think prone to release the posterior SI ligament and the sacrospinous from the sacrum, and then release the SI joint too. And then supine to release the anterior SI joint, and then do osteotomy. And then we'll put on traction. And to see how it is going to reduce. I think I think I would do osteotomy at the cora, the pubic root. I think if it's inferior to the weight bearing dome, it's okay. And then another one at the pubic rami, and you can maybe rotate. So I think a prone to release ligament, anterior to release a joint and do two osteotomy.
Any other proposal?
Not sure. I'm still not sure. So.
So first step, posterior release, SI joint osteotomy, sacrotuberous and sacrospinal ligament release. This is the approach. This is the approach. And you have here chisel for the posterior, then anterior release, anterior ring osteotomy and traction. More or less what you did propose. Now, what do you say?
Maybe you use the distractor to derotate the internal rotation.
So we have skeletal, supracondylar skeletal traction, and you can see I have developed this big device with an X-fix in order not to damage the soft tissue of the leg, and then to have someone pulling distally. And sometimes you can engage to the table. And the femoral distractor to externally rotate. And this is what we have obtained. Any comment?
So in this case, you do traction before fixation. So it's a how it's a two-stage, right?
But if you take a careful look, I did open here and I put bone graft by the front. The bone graft is fibula graft. And here you cannot see properly, but from this arrow here until here, it's a fibula graft, almost 3 centimeters, in order to maintain the space that I did gain through the osteotomy. And I've done the osteotomy not at the level of the hip joint, immediately distal. At that time, I didn't realize that sometimes you need much more release, that this release coming from the sacrum. And then later I realized that release from the ischial tuberosity is almost necessary. So this is the sitting imbalance X-ray. This is the original shape of the pelvis. And this is the actual shape of the pelvis. So you can see the shape originally and how it is right now. It's not a perfect situation, but it's much better than it used to be. And you can see a 1-year follow-up with the osteotomy heel in the front, and how it is. It's unfortunately it's a short X-ray film, but the sitting imbalance is almost totally corrected, because fortunately for the surgeon and the patient, when you have a difference in height less than 1.5 centimeters at the ischial tuberosity level, it can be very easily compensated. What I learned later in other cases is you can make an osteotomy of the ischial tuberosity and make a shortening if there is certain amount of residual difference in height and sitting imbalance, and it is much less aggression than the pelvic osteotomy. And you can see it's not perfect, but it's much nicer than it used to be. Questions? Because I know there are some cases from some of you. This case was done before in time. So there is some issues I learned from this case I did apply in other cases. One of the issues, what I learned is I did put a tension band posteriorly, because while I take a a picture after the femoral distractor in place, I've seen the opening of the SI joint. So when you try to correct the rotational deformity using the femoral distractor, even the SI joint has no problem. The ligaments of the anterior SI joint component, they are going to be stretching gradually. So you need to protect either with percutaneous screwing or with a tension band plate.
Can we ask how long was the surgery? Just to have an idea, and how much bleeding for this type of surgery?
This kind of surgery usually takes in between 8 and 10 hours or 12 hours.
In one
one
stage?
Yeah.
Oh.
Sometimes it is 6-7 hours for the complete release of everything, another 6 hours to the assembly.
So 6 or 7 hours each. And what about the blood loss? Usually?
Sometimes it's a lot, but with the time you know where not to go. So if you have a bleeding, or the bleeding sources are this scar tissue inside of the pelvis, scar tissue outside of the pelvis, and usually the bleeding, this bleeding can be controlled by packing. Some other source of bleeding is related to the superior gluteal artery because you are working the proximity, but you can manage it without any inconvenience. Never suffer a bad casualty.
Okay. Thank you. So next, we have a case from Dr. Apipope.
Thank you so much for sharing an amazing case to us. We learned a lot from you, Professor. So this is just short case sharing of non-union, malunion of pelvic case that I have done with Dr. Rahut and Dr. Surapong for many years ago.
Okay.
We're just case sharing is we have done many years ago with our team. In this case, I invited Dr. Rahut and also Dr. Surapong to help me. So first of all, I would like to thank Dr. Rahut for inviting me for sharing the case. So we just finished the favorite course in Chiang Mai. So thank you so much for coming to Thailand, Professor Carlos, and thank you so much for class distributor during our course in Chiang Mai. So the case is young female patients. She got the pelvic fractures, it's open injury for 1 year ago. And she came to me after 1 year, and she has a problem with the sitting imbalance, back pain, and also so much pain on the left side joint. It is a soft tissue condition. I think she was performed abdominal injury before, and a lot of scar in the abdomen. Okay. Next. So these are X-ray of her. It's a lot of problem. It's SI joint non-union on the left side, and also the vertical shearing on the left side as well, and also have a problem with the scar on the front. So you can go to the X-ray of this. So we would like to take a look on the CT. The problem is non-union on the left SI joint, and also the malunion of both superior lemmi and also the symphysis pelvis. And this is a CT 3D. So next. So something like this. So I think this is indication for the surgery because she has pain and also deformity during the cystic imbalance and also the limb shortening in this case. So before before you start to do the surgery in the case like this, I think it's important to talk with the patient because the patient need to understand the goal and expectation, and you need to inform the patient that after you do surgery, the pain improvement is more reliable than the instability. Another thing is the surgery should be really long surgery, and she did a lot of blood transfusion, and also the post-operative limitation weight bearing at least 3 months, and also the time for return to normal function is maybe 1 year. And more importantly, I would like to emphasize that you need to inform the patient that the surgery has a high risk of complications, about 20 to 30%. Would be the bladder and vascular injuries, a lot of reduction in persistent non-union, and also the chronic pain after the surgery. This is the important information that you need to inform the patient before. So and if you would like to do this kind of reconstruction, latest reconstruction in pelvic surgery, fractures, you need many things here. You need expert trauma team, pelvic expert trauma team. You need a lot of things, and you need to do pre-op planning very carefully. You need an ICU post-op, and also you have a good team. You need to have a good team of the anesthesia. And this case I performed in September 2017. That told you that I invited Dr. Surapong and Dr. Rahut to help me to doing this case. So the first, we plan to do the 2-stage procedures. First stage, we set the patient supine, and we do the ideal approach. We release all the scar and anterior ligament to the symphysis pelvis to the left SI joint. And as you can see, we free the symphysis pelvis, and also we free the SI joint on the left side. And then we turn the patient prone. We do the scar resection, do ligament release, sacroiliac and sacrotuberous ligament. And after that, we take out the patient and do the distal femur tractions. And after retraction, you can see that we can bring the whole left hemipelvis down almost in the normal position. But the problem is that I already told you is after 1 or 2 days after surgery, there's some fluid, a lot of fluid come from the surgical site and anterior part. And this is not a blood fluid content, it's a yellow content. So we realize that some problem happened. So it's like urine. So we consult the urologist and they do the exploration and we found there's a big hole in the bladder. And we have to do the urologist have to do the repair the bladder. And because of the scar tissues, the surgeon do the repair with the orbital flap. So we have to wait for 1 month in order because of this problem. So we take a patient back again and do second stage by go the superior first, do percutaneous SI screw, and also anterior first, we do percutaneous SI screw on the right side, and also do FI joint fusion on the left side with SI plating. And we turn the patient prone and do the very strong fixation on the back by using the spinal pelvic fixation. And because of the bladder complication, so initially we plan to do some plating on the front, but because of the bladder injury, so we cannot do anything more than this, just do the egg fix. And this is the final fixation of the whole of the reconstruction. So when you take a look, you can bring the left pelvic down a bit. It's a bit better than before, but the problem we cannot collect more rotational deformity because of we cannot do anything on the front. And this is 4 months. We remove egg fix, and this is a clinical pictures. Next, 6 months. You can see the. Can you play the video? The previous. We still have some shortening about 2 centimeters, but she can sit right now. And this is 2 years that we remove the posterior spinal instruments. Yeah, that's all, Professor. I think this case, the problem is a bladder injury. So any comment or suggestion? Yeah.
Recently, I have a correction of deformity very similar to this one, with original disruption of the bladder when the patient suffered the accident. And we did the reconstruction 8 months after the accident. And after performing the release and reposition of the hemipelvis, we suffer exactly the same situation. 2 or 3 days later, the fluid started to come from our fan steel approach. What I guess in that situation was because of the traction created for the reposition of the hemipelvis. Even though I did release everything from inside and from outside, the original disruption of the bladder was recreated because the scar tissue is not as flexible as the muscles of the bladder. So I did repair personally with my team once. 2 days later, the same situation. We did repair it again. This time we asked the urologist to come and take a look. They say, well, you have done a good repair. 3 days later again, so I took the rectus abdominis, cut the distal insertion, and transferred from anterior to posterior in the pelvic ring. So the rectus abdominis was closing the bladder hole. It was a flap instead of omental, but I didn't remove the osteosynthesis of the pubis. My osteosynthesis remained in place even though it was infected. The problem is the intensive care unit people, they gave antibiotics, and the infection was related with the previous bacteria was multi-resistant. So the antibiotic created condition for renal insufficiency. And renal insufficiency has a period of production, a lot of volume. And because of that, the fistula didn't close, even though I put the flap. He has a volume of 6 liters from the fistula and 4 liters from the Foley catheter. Gradually, when the renal insufficiency was subsiding, the volume was changing, was diminishing, and at a given moment, we changed the volume, so the fistula was releasing less volume than the Foley catheter. And then you have to make some changes in the position of the drainage of the fistula. And in order to protect my reconstruction, I put some pellets of cement loaded with antibiotics and didn't remove the reconstruction in the front. So the end result was a relatively well-balanced pelvis. And what I learned with the time is that I do not hesitate in doing osteosynthesis in an already infected pelvis, because if the patient has one infection, it's not going to have 2. It's going to have the same infection. What you need is stability. Don't wait so long time, because it happened to me once, the same situation. I have done the release. It was in a different hospital than mine. The urologist said, no, don't do surgery, you have to wait. While I was waiting, my posterior construction was loosening. Since that, I assumed the risk of performing the osteosynthesis even with the rupture of the bladder, but I tried to perform the best biomechanic construction. And by doing this, I'm going to be less involved with residual migration or secondary migration, because you have done a good job with the release. Waiting such a long time, you cannot control the retraction of the hemiperioneum you have already released. So it is, for me, preferable to do percutaneous screw in the back as a temporary fixation, a plate fixation in the front, protect your fixation with antibiotics, wait until the bladder is already healed. If you need, you can change your spacer for a new set of a spacer, but don't allow the already released hemiperioneum to be absolutely mobile until the bladder is healed, because otherwise you're going to have secondary displacement. But you need to obtain certain amount of consensus between your colleagues, because if the urologist writes, do not touch, or the infectologist says, do not operate, and then if you do something and something wrong is going to happen, you're going to be in jail. And several times you are going to be the only one who has much more experience, because maybe today's urologist number 1, tomorrow in another case, urologist number 2, in 2 years, urologist number 3, but you're going to be the same during this whole period. So you are going to be able to conduct your colleagues, because urology has a lot of experience in rupture of the bladder, but not rupture of the bladder with an unstable pelvic situation.
Thank you so much for your comment. So when you put the implant in and you put the antibiotic cement inside spacer, you put in front of the symphysis, right?
Exactly.
And you, how long have you, can we leave that, or?
Usually after 6 weeks, I remove it. If I need to change, I will change it before. But if the infection is already healed and the fracture is already healed after 6 weeks, it has nothing to do. So I try to remove it in order to have no foreign body. And because, the membrane, the concept of muscle, it's going to happen around the pellets. Yeah. So this is not going to collapse. Okay. So I remove everything and take a look, take a sample. If I need to put a new set of dispenser, I will do it. Yeah. I will gain time by doing this. If for any reason I need to do bone graft, after removing the pellet, taking a sample biopsy to check if there is residual infection, I'm going to use bone graft loaded with antibiotics. The same you do in the tibia, it is much easier to do in the pelvis.
Yeah. Thank you so much.
Okay, so I think one more case before we go to the lunch.
You hungry?
Do you want to go to lunch now? Or
The participant, not me.
I
Yeah.
I think one more short case, and then we move to the acetabulum in the afternoon. So, okay. So I think this is another case. So it's 70 years old. She was ran over by a pickup truck, and she was initially treated with an anterior X-fix. So she has a extraperitoneal bladder rupture with a suprapubic cystotomy, a urethral injury, and a vaginal injury with a UV fistula. So she has a complaint of the deformity of both her legs and a severe pain in bed, and she cannot sit up, and she has a pressure sore at her buttocks. So this is her clinical. So you can see that is immediately you can see the malrotation of the right internally and left is external rotation. So initially should be a LC3, and this is the suprapubic cystostomy because she has a UV fistula and the urethral injury. And when we do the per vaginal exam, you have a bone fragment sticking into the vagina. So this is X-ray. So I think the main deformity of this case is the rotational. So it's a LC3 that it has already malunited. So next time I will draw the 3 lines, but this one I haven't drawn. So, but it's mainly the internal rotation of the left and the maybe both. It's like a crush. And the fracture was already malunited. So you have a malunion of the sacrum, is a shortening of the both sides, and then internal rotation of both the hemipelvis. Okay, so yes, so this is the situation. So what I did, I planned for 2-stage approach. So I try to correct deformity by release and distraction of the soft tissue, and then I would to fuse to stabilize the pelvis. So in this patient, because I think the main deformity is rotation, so I release in this symphysis. So in the beginning, you can see that there's no motion when I put the X-fix and try to external rotate the pelvis. So I have to release the symphysis, and then I release both the SI joint because I don't think I want to osteotomize the sacrum. So I think I will create instability at both the SI joint instead. And after we do all the release, then we can correct the deformity. So you can see that we can move a little bit the external rotation, but still it's not enough to correct the deformity. So because the bladder injury, I don't want to release more. Intraoperatively, there is no urine leakage. We test with the methylene blue to push it inside to see if it's a bladder leakage or not, but there's no pigment leakage. So I put external fixator, femoral distractor, and I plan to gradually distract. And then I put the patient in this because I feel that we cannot correct all the deformity yet. And then I do gradual distraction at ward every day. So I let the patient turn herself until she feel pain, and then we stop. And in a few days we turn again. So it's gradual turning every day at the ward. So it took about 8 weeks to correct the deformity. But there was then some urine leakage. So I think maybe we distract too much and it was scarring. So we had a very bad infection. And then we consult the urologist and do debridement, but the urologist said we cannot do anything. So we just treat it by conservative treatment. But he said it will heal. The bladder will heal itself. So I just pray. But she was able to mobilize with the distractor. So this is the correction of the deformity. And then after that, we can control the infection. So then we go and you can see that even though we correct the bony deformity, but the muscle and the soft tissue is still contract, like Professor Carlos said. It takes time to get back. So even though we correct the rotation, it's still like seem like the left leg is still very externally rotated. And then I changed from the distractor to X-fix to maintain the deformity, and I fuse the SI joint with a dry cortical stud graft, both sides, and fix with the plate. I cannot do anything in the front because I'm afraid of the infection and the soft tissue and everything. So I decided to just put X-fix for definitive treatment. And this is the final CT scan. You can see that we correct the malrotation of both the iliac wing. So we leave the X-fix 10 weeks. And then I start to see the bone formation in the front, and the patient is already walking with the X-fix. She feels much better. So I decide to remove the rod and then do a weight-bearing film. So it's not moving anymore. So we decide to remove the X-fix. So now it's 1 year. She has correct her urologic injury and repair the vagina. And this is the follow-up. 1 year, she's sitting better and she can start to walk much better. And this is 1.5 years. You can see we correct the deformity into this. And then this is the CT scan. So this is her, yes, this one. So I was very reluctant to fix on don't fix the anterior ring. And if I don't fix, I was thinking about doing the spinal pelvic fixation. But in this case, I didn't do because she had a big pressure sore in the back. So that's why I was reluctant to do the spinal pelvic to protect the construct. But because she was so sick, she remained on bed for many years. After discharge, she was still only wheelchair ambulation. So she started walking almost a year. So that's why I didn't. It would be safer to neutralize with the spinal pelvic fixation, I think. Yeah, yes. But I don't want to have another infection at the back. I did not take a picture of the pressure sore, what it was very bad. But you can see that she was very thin, right, on the clinical picture. So, but luckily she did very good, and now it's 2-3 years out, and she's almost perfect, normal. Thank you. So, yes, please. Which slide you want to go? Okay. After the osteotomy, after the first release. This one? Oh. Yes. I released through what I thought to be the fracture. Yes, because here. But yeah, like, but I go to I think I go to the fracture here. There's a picture. Symphysis both sides. I only release here. You see the here, and then the motion is here. So I follow the fracture, but I'm not sure. I cannot identify the symphysis anymore. She was they divert the urine through the suprapubic cystostomy, and I was afraid that I will rupture the bladder, so I was very careful not to disrupt the bladder. And she also has a UV fistula, but I think is the inferior part, so I'm not too worried about that. And urethral injury as well. So I just verify that I don't rupture the bladder with the methylene blue through the Foley catheter. No. Sorry? Yes. The urologist cannot do that. Actually, I did this when I finish.
Have such a configuration of four rami fractures. Several times the bladder or the urethra are entrapped in this line, and then if you correct, sometimes you can release the tissue which is entrapped, which is one situation. Different situation is the urethra is already broken first, and then I like the idea of the femoral distractor very much. In the case of an infection, probably you have considered next time to put a dispenser of antibiotic, local dispenser. Because the local dispenser, you can use it also as if it's a block, in order to increase the stability of your construction. And then you can bone graft the deformity, the residual deformity, in order to make a faster healing time. But the problem is not the infection. The problem is the presence of the suprapubic catheter. And but I congratulate you because you were brave to open bilateral DA joint with the front, even though with a history of having because for sure she had an infection before of the abdominal wall. And can you go back? Could you advance a little bit? It is very nice the way you did open the front of the pelvis. There is another possibility instead of the femoral distractor or the X-fix at the end is to put infix. But I do not recommend to use the infix in cases of active infection. But in those cases where you don't have bone in the front, the infix is a very good alternative. And in order to increase the stability of your construction, maybe if you are not going to use the plate, the recon plate in the back, you can put much more screw from one side to the other. Including if you have long screw, one screw as a sacral bar in the same position, retrosacral screw. So you don't need, if you have this long screw here available, you don't need to open like for the tension band plating, because you can do it percutaneously. But it's a superb case. Congratulations.
Yes. Okay, thank you. So I think we stop now for lunch, and then we may come back. I think Dr. Kantapon can present one case geriatric because we already ran out of time, and then we continue in the afternoon with the acetabulum. Okay. Thank you. So how long? I think half an hour for lunch, maybe 20 minutes. Is it enough? Yes. Okay, thank you. Okay, so I think in the afternoon we will have a discussion about acetabulum fracture. So we have one case of a geriatric acetabulum fracture from Dr. Kanpon and one delayed acetabulum from Dr. Teshit. So I think we can start now.
Okay, so hi, I'm Kantapon from PSU Hospital. So this case, it was done when during my fellowship year with Dr. Apipope. So he was a 90 years old male who was still quite active. He was riding a bicycle and fell down. So the X-ray showed that he had previously have right hip fracture, which was united like some times ago. And this time he have a really severe right hip pain. So the X-ray show only a faint line on the iliac wing on the right. And we cannot really see anything much after that. And on the left, you can see that there's a anterior column fractures that go down to the just distal to the pectineal eminence. So the on the 2D view, so we can see a little bit more clearly on the iliac oblique view that the fracture line is really just non-displaced or just a little bit. So we can see on the axial view of the CT that it is the joint. So it just displaced for a little bit on the anterior, but the joint looked really good. Only some displacement at the inferior part of the wall. So in this case, I think we can say that we can do conservative if the patient is not very painful, but he have a very severe pain and cannot move, ambulate at all. So we decide to operate on this case. So we think that it should be operated in a minimally invasive manner. So what we did is that we try to do limited open reduction of the iliac wing by doing the lateral window first, and then we put in one leg screw on the iliac wing. And then after that, we did the percutaneous LC2 screw like this. So we check the obturator inlet and the obturator outlet. So the pin is in a good position, and we want to be sure that the screw goes back to the very distal of the wing. So since our hospital, we have and then we do the percutaneous retrograde column screw, because the two fixation point here is only fix the wing part, right? So the anterior column part is that have the weight bearing dome is still not quite stably fixed. So we do the retrograde rami screw percutaneously and check with the obturator outlet again, like this, as we are familiar with. So after this, we see that these two pins are kind of crossing each other. So we are not sure if they will obstruct each other or not. So we can, but fortunately we have the 3D imaging, so we can check intraoperatively that it really go to the back on the LC2 screw. So we can be sure that it can hold the fracture stably. So after that, we put in the screw, the retrograde column screw and the LC2 screw. And they kind of like it like have some how to say it? Like interdigit a little bit, which I think may be a good thing. But yeah, anyway, so after this we got something like this. So 2 small wound and the lateral window, which is not very big, and the post-op fixation looks like this. Immediate post-op, he was not able to walk right away, but he can sit on the bed and he can transfer to wheelchair. And after that, and we also do the post-op CT scan. So at the 6th week, he already back to ambulation with walker, and he lost follow-up for some time after 3 months. But the last night I checked, so he came back to one of the OPD for follow-up with gout, and they said in the OPD card that he was able to go back to cycling again at 6 months. Okay, thank you.
So can you go back to, yeah, so what do you think about, it's minimally displaced, right, do you think?
Yes.
And can you go to the AP X-ray?
This one?
Yes. So why do you think, can I have your comment? So it looks very minimally displaced, right? Would you be worried about this displacement, the ischium? You think it's something there, or in this case?
Take a look to the CT, it seems that this is not such a big deal. However, with all individuals, you never know what's going to happen. But can I see next slide? If I were my case, I would try to fix percutaneously almost every single fracture line. No doubt about it, especially in this patient population.
So you think intramedullary screw is, because there is one caution about the severe osteoporosis and the retrograde rami screw. Do you think it's strong enough?
You need to reach the opposite cortex. If you reach in the opposite cortex and you engage the opposite cortex with the screw, it's going to be fine. I have no doubt about it. I do screw every single fracture line in the elderly.
Okay. So excuse me. So do you also do the percutaneously on the iliac wing also, right? Yeah. Oh. So how can you share like some techniques that, like how do you like do that, or the X-ray view that
for the iliac wing?
Yes.
It's not so easy. It's easier to put the supraacetabular screw because in order to find the safe corridor, I do propose not to use the anterior inferior iliac spine as a spot because it's a very narrow spot. You can go a little bit much more laterally, and you can find a corridor that goes from anterior to posterior along the wider and stronger part of the pelvis. The iliac crest itself you need to open.
Oh, okay.
Because it's not so easy to do it absolutely percutaneously.
So what Professor Carlos mean is that, so what
the professor mean is that if you aim for this, it's very narrow and it's easy to slip off the edge, right? So we recommend to go more lateral. Lateral is a very thick bone and wider, and you can aim, you know. So it's much less chance of going out, slippage, because you aim this direction. So if like this, you will be perpendicular to the cortex. But if you go inside, you can slip, right? And can miss. Okay. So I think Dr. Teshit will present one more case. This is a little bit delayed acetabulum case, but maybe not very delayed, right? How many weeks? Okay, please.
Okay, mine is a both column fractured acetabulum. So he's a 61 years old male with a pickup driver with a rollover accident. The date of injury is on 25th May. And the first hospital delayed the surgery due to the patient alcohol withdrawal and also the SIADH with hyponatremia. And after some times, about third week, the surgeon at that hospital decided to refer the patient into our hospital due to the lack of equipment and due to the late case. So this is an initial film from the first hospital. As we can see, this is the obturator, the AP, and iliac oblique. So this is a so-called not so-called spur sign, but this here is a dome is displaced and already detached from the innominate bone already. So this is the both column fractures. If this is a acute case, is not much to discuss. It's not that interesting that much, but now it's 4 weeks already, so we decide to send another CT. In the CT, we can confirm that this is a both column fractured. This is a so-called spur sign here, which is still attached to the denominate bone, but you see it's already not attached to the dome anymore. But other than that, you see a lot of callus here and there.
So, Professor Carlos, do you think this is a lot of callus or a little bit? On the axial view, เตชิตย้อนกลับไปหน่อยดิ
Where is the cup?
There.
It's not
No callus. Okay, okay. So it's fresh.
Almost fresh.
It's 4 weeks. It's still fresh for you. These they don't concern you. Okay. So. Okay. This is
Going to operate.
yes, we
So you're going to remove any kind of information.
okay. So go next.
Yeah.
So 4 weeks for you is still good, right? Still good.
Yeah.
What about here, the coronal view? It looks
The case after 8 weeks.
no, it's only 4 weeks. So, but this is it doesn't concern you, the callus here.
But you need to clean it.
Yeah, okay. Me 3D ป่ะไม่มี you can see. Oh, but this is delayed a little bit, maybe.
It's a tibia fracture. Do you have any concern in a tibia fracture if you have callus formation? and you need to correct the deformity. Do you have any concern, Rahat?
For tibia?
4 weeks.
No. tibia is okay.
You have concern in the acetabulum because you're afraid of the exposure, not because you are afraid of the lapse time. It's an articular fracture. You have to clean and try to do anatomical reduction, and that's it.
So we look at the lateral. If you see like this,
it's fine.
Okay. So good.
Okay, but
so
but for me, for the novice like me, it's not.
so what do you
I,
think about the callus here going? Is the scar or going here?
You have to approach anterior and posterior after 3 weeks at the same time in my hands and clean everything from the fracture side. Release what is necessary to be released, and you're going to succeed, no doubt about it.
Yes, and what do you think? You think we can do this safely until how many weeks?
5 months?
5 months. Okay, 5 months. Oh.
okay, shall we proceed?
But you can do it.
ต่อเลยได้เลย
Okay, so for me, since I'm a novice, so I need a lot of help. So I do the segmentation of this acetabular fracture to differentiate the fracture line and to communicate better while doing the operation with my team. So I know exactly where I'm going. Yeah, so our plan is to release the posterior callus from posterior approach. Yeah. Okay, so we start prone first. We try to mobilize the fracture, but it's not moving. Okay, so we start prone and remove the callus, and after that, we try to we use a laminar spreader and try to mobilize the hip joint and see if the fracture is mobile enough or not. Yeah. And this is intra op on the posterior side. We free the ischial pubic segment from the ilium fragment. Yeah. And then we flip the patient over and remove the callus further, and with the anterior column reduction and screw fixation and anterior column plating. This was done by Dr. Rahut. We have to invite him. Yeah, and also there is posterior superior dome fragment with which we already clean it from the posterior side, but we need to clean it further from the anterior side on the outer window of the ilium. This is that fragment between the blue and orange fragment on the right side. Yeah. So a lot of callus, but not too much for you, right? Okay, so until we see the spike of the fracture line clearly, and then we use the asymmetrical clamp to put it back. Sorry, it's two-prong clamp, and reduce the dome. Yeah. And then we put a screw to fix it, like so, and then finish it with the posterior column screw, and also the infra screw. Yeah.
So I think this is a case to show that even though the reason I emphasize this because I see many cases after 2-3 weeks, they would do nothing. You know, you would just leave the patient. So I think like Professor Carlos said, you can do it. But I think for more than 2 or 3 weeks, you may have to consider combined approach. So in this case, you have to release the posterior column first. If it was a fresh fracture, you can do everything in the front, right? But for cases like 4 weeks like this, even though it's not united, but you have a lot of scar and healing tissue. So if you start from the anterior, you cannot get a good reduction. And then you start to struggle. And if you don't stop, you will injure something. Maybe, from your dissection. So you have to know your approach from the posterior, how far can you go? From the anterior, how far can you go? And you have to plan. So it's a one good thing. But I see many cases after 2-3 weeks, they don't even bother to refer the patient anymore because they think it's too late. Okay, so it's still possible. Even if it was more than a lot of months, maybe we will ask for a professor's help. but I think 4 weeks, 6 weeks, 8 weeks is still very much possible to do the reduction. I show this because I know that you will see a lot of cases, and please don't, you have to do something as soon as possible. Okay, so thank you. So now for you. Yes, now it's your time. I hope you're not too tired. Okay. So I think if you look at the literature, it's they divide it into before 3 weeks, right? And 3 weeks to 4 months and more than 4 months. So if it's less than 3 weeks, it's very good result. If you have a good reduction, maybe 80-something% of good to excellent result. If between 3 weeks and 3-4 months, then maybe the good result is drop down a little bit. But if you have more than 4 months, 3-4 months, then we don't see the fracture anymore. Maybe it's already starting to unite it. So you have to be approached in another different approach. So I think then you would have to decide not just according to the fracture, but according to the timing of the operation that you have to do on the patient. Okay, so please, this is a good consideration. So if you see the case, then you have to do as soon as possible. But if not, you have to refer as soon as possible also. So the later is the more difficult, I think. So we will learn more about the late presentation of acetabulum fracture of Professor Carlos. Okay. Yes. Yeah. And I will use still it in the internet. Okay, good. The Zoom. Yes. Yep. Yes.
It has to be this one. Yep. Okay. Now it's good. Okay. Now it's good. Just turn off the video. Okay. Okay. Okay, perfect.
Okay. Now we are going to discuss some. Yeah. Now the problem is the lapse time. So we are going to discuss briefly some cases. And okay. So between 3 weeks and 4 months, it's still possible to see the old fracture lines. Osteotomies are very often needed to free bony fragment, extensile approaches, simplification by healing of many fracture fragments. Next, please. So this is a 55 years old female. She is an American, she's an employee at the American Embassy in Argentina, working in a research project in the middle of the equipment in Argentina, equivalent to the Everglades in Florida. Referred with ipsilateral infected open ankle fracture. She was ready for surgery 5 weeks after trauma. Who wants to be the surgeon? No one? I wanted to be the surgeon at that time. This Rahut. These people don't like to work. 5 weeks. 5 weeks.
ใครนะ อ๋อ โอเค โอเค พรศักดิ์ พรศักดิ์ It's you are my old fellow so you have to speak
Okay, okay, I think the problem is the patient got I guess it's a T-type with posterior wall fractures and is left untreated with the posterior hip dislocation with the fracture neck fractures and also has passed 5 weeks. So it's, my concern is about the fibrous and maybe some callus formation in the posterior. So I guess the main concern of my concerns is in the posterior. So the first thing that I would due is posterior part, and another point is anterior about the acetabulum from the front maybe have to be the cals maybe have to deal with. So if my preference, I would do the anterior approach first to do the to remove the callus from the anterior. So then I will would flip patient into the prone position and do the maybe the in the lateral decubitus and do the posterior approach. And I think if the front is clear and we can approach the posterior, maybe I could do the fixation from the posterior alone. Okay.
Next. Any other proposal? Who knows? Do you perform total hip replacement? At 6 weeks, at 5 weeks.
What do you think?
It's a good case for a total hip replacement.
I think it has a fracture of the proximal femur too. I think is.
So we have a fracture line here that goes from anterior to posterior, here and here. So it's a T-type plus posterior wall plus femoral neck plus intertroch plus subtroch extension. It's a good case for a total hip replacement. Why not? You say no, he says yes.
No, I think it's difficult to do hip replacement.
Hip replacement?
Difficult to do hip replacement.
It's a difficult hip replacement. Yeah. Okay. And for you, it's difficult or easy? Difficult. Who considers this is an easy hip replacement? No one? Come on. You are hip surgeons. You're going to be in the hip course at the end of the year in December. Is it easy or difficult? Difficult. Not good candidate because of the age, 55. It's older than you. It's an old lady. For me, it's a youngster. Okay, so the problems here are related with the configuration of the fracture, the lapse time, the infection at the same limb. Sometimes, I'm not so sure which is the evidence, but Letournel didn't perform ileoinguinal approaches in patients with infection in the same limb because he wanted to avoid to manipulate the lymphatics that were draining the infection of the same limb. I'm not so sure if this is correct or not, but put it in your box as another complication. So we needed to wait until the infection of the ankle was already treated. She was ready for surgery after 5 weeks. Next, please. So as a summary of the problem, she has a dislocated hip for 5 weeks, the acetabular fracture, the proximal inferior fracture, the ankle and the time. Now, what do you think about the blood supply of the femoral head after 5 weeks? Is it going to be okay or not? Are you believers? If you are believers, you have to believe. Otherwise, if you are skeptical, if it were an isolated femoral neck fracture in someone who is 55 years old, is she a good candidate for a hip replacement or not? When do you indicate hip replacement in displaced femoral neck fracture? Garden 1, Garden 2, 3, 4. You said number 4. I read your lips. You said number 4. I read your lips. Number 4. Which is the number of this? Number 4? It's more than number 4 because it's also dislocated. So she is a very bad candidate for any kind of treatment, isn't it? However, we need to do something. You can perform a Gittleton procedure. This is it's a good procedure for someone who has not femoral head viable, and that's it. Drop it, go back home. It's a procedure. Maybe, or go ahead. Callus formation. You were afraid of the 3 weeks callus formation. Are you afraid of 5 weeks? Okay, gentlemen and lady, or lady and gentlemen. You know, it's a 2:15, and we need to resolve this case before 3 minutes. So, do you want to work as a team, 2 or 3 or 4 of you, and try to figure out which one is going to be your treatment, or a volunteer is going to be asking for the whole group, on behalf of the whole group? Do you propose a team approach? Yeah. Please select your team, because it seems that only one is not enough. He said he is a hand surgeon. Are you a hand surgeon? Oh. No? Okay, so we need 3 or 4 of you, team approach. Otherwise, everyone is going to get sleepy sooner.
For this team.
Okay, so 3 minutes to prepare the case. Do you want to search into literature? Remember, there is a piece of bone here also. Huh? Don't worry, don't forget this piece of bone.
Are you ready?
I think maybe I never ready, but I will try. Okay, so we think we go because there is many problems, so we think we will operate at the femur first. So we decide to place the patient in the lateral position, and so we think about open reduction the femur first. So we decide to do in the same setting for the acetabulum too. So in the because we have to do two two operation in the same setting. So we have to decide which approach that we can do to fixation in the same approach. So I'm not sure that we can do it in the same, but we think I am going to do the extended iliofemoral approach. So, but inside I will try to open, reduce the proximal femur with temporary fixation with the wiring first, and put the cephalomedullary nail in the femur first. After that, if we done it successfully, we will try to remove the callus from the posterior of the acetabulum and try to fix the posterior column and posterior wall. For the anterior part of the anterior column, I think we will put the anti-gate anterior column screw.
Okay. Sounds good. So lateral decubitus, extended iliofemoral approach, release of all callus formation for anterior and posterior, then reduction and fixation of the femur. This is the sequence. And then reduction and fixation of the acetabulum. Okay. Let's see. Uh-oh. No bleeding. The femoral head is not bleeding at all. Is there any change in your plan?
I think we try to fix first because we have to build off metaplasia. Then we can go to total hip resettlement in the future.
Yeah, fusion.
Yeah. Future
Okay.
in the future.
Hip fusion.
No, hip in the future.
No,
later.
But you don't have any concern about the avascularity of the femoral head. Is anyone having any concern about the avascularity of the femoral head?
Maybe it will vascular necrosis of femoral head.
Okay. So I'm going to tell you what I think. That I wanted to check this by medical legal reason, but after 5 weeks being out with this long distance in between the femoral head and the proximal femur and dislocated, I was almost sure that it was a necrotic femoral head. However, I wanted to perform a reconstruction of the whole thing. And in order to reconstruct everything, I decided to put the patient, as you said, in the lateral decubitus. And you can see my lateral decubitus over there. But this is not extended iliofemoral approach. This is a Kocher-Langenbeck. Next, please. So the reconstruction for me has this rationality. It was reduction fixation of the posterior column because it was easy. Elevation of the posterior wall, marginal impacted fragment, reduction of the femoral head, fixation of the proximal femur fracture, reduction and fixation of the posterior wall. That was my sequence, a little bit different from your proposal, because it was easier for me to release the anterior column component to clean with the dislocated hip. Nothing in between, so I was able to clean everything from the hip joint because there was no hip femoral head in both. So after that, so the posterior column was very easy to be reduced, and then I fix it. Next, please. And this is 1 year follow-up. Do you agree? You can say no. It was already done, so no, there is no other possibility. Does it look okay? No comments? The reduction maybe is not perfect, but it's very close to anatomical. And at 1 year follow-up, it seems that the acetabulum did heal. The femoral head is still viable. The femoral neck fracture did heal. Maybe the problem is the PFN, but that was the available negative time. Next, please. And the intertroch and subtroch fractures did heal also. So all the fractures already healed at 1 year. So now, are you happy? For how long? A couple of years. Do you think that we have a vascular necrosis? It was already avascular at the moment I have done the surgery. There was no bleeding at all. So we are just waiting for the development of the complication, but it was already avascularized. It was no bleeding. So what we wanted to have is already healed acetabular fracture, already healed proximal femur fracture, and in the case we need a total hip replacement, it's going to be a primary one and not a very complex total hip replacement. So next, please. At 2 years, there was certain changes in the femoral head that they are anticipating the end result. Next, please. And this is the 3 years end result, which is a primary hip replacement and not a complex. So it is much easier to perform a hip replacement when everything is already healed than try to do a replacement from the very beginning. We can argue that she was waiting for something, okay? But even in the hands of those who are extremely expert in hip replacement, this is a very difficult situation because you need to do a revision surgery from the very beginning or a curvable ring, a reinforcement, or something which is much more complicated. Okay, let's see, combined approaches. Now this is 22 years old. He was treated conservatively in the northern part of my country, in the limit between Argentina and Paraguay. And this is the displacement of the both colon fracture. You can see the anterior colon component, the posterior colon component. He was referred to our place in Buenos Aires 2 months after the accident. So you were afraid of 3 weeks. This is 8. Next, please. So proposals, surgery or non-surgery. I was invited to a consensus meeting in the hospital when this was patient where he was as an inpatient, and the so-called owner of the patient proposed to perform a hip fusion as a primitive primary treatment. 22 years old, hip fusion is okay? No? I said no. Hip replacement at 22 years old? No, why not? You don't like the hip replacement. You know, hip surgeons, they make a lot of money performing hip replacement. Much more than trauma surgeons. Everywhere. I don't know here in Thailand, but this in my country, in the United States, in Europe. And they are much more elegant surgeons. They have limited amount of blood everywhere. So you prefer to do a reconstruction? Let me know how. Who is going to tell me the problems we are facing here? Yes, yes.
Okay, so of course we are facing the quite complex case with delayed presentation. So from the X-ray, I cannot see it clearly because of some underexposure, but I clearly see that the posterior column is quite displaced medially, and at least I think I cannot see the ilium clearly, but it's disrupt both of ilioischium and ilopectineal line with I'm not sure that the fracture also entered the obturator foramen or not, but in the obturator oblique, I can see some fracture line at the pubic tubercle. No, at the inferior rami entering the obturator. So right now I think it's more like the T type. Yeah, and quite displaced medially on the posterior. Yeah.
Next. No, go back. So did you see the color formation in the CT? Because you cannot see the color formation nicely in the X-ray because it's very dark. But this is 2 months after the trauma with this huge amount of color, so we need to release everything.
So I have to change my diagnosis because this already disrupt anterior column on the axial view. So I don't see the entire CT, but at least this would be ACPH or both column.
For me, it was a both column.
Yeah.
So our strategy was to make a perineal approach, limited perineal approach, and make a osteotomy of the obturator foramen, then ilioinguinal approach, the release of the calf formation, release of the obturator nerve from the calf formation, release of the medialized fragment, and posterior approach, cochlear ligament at the same time in the so-called floppy position, and release of all the calf formation from the posterior approach. And when everything was ready, we performed an osteotomy of the ischial spine, and then the ligament was already released by doing the osteotomy, and then posterior and anterior column were ready to be mobilized. Can we see next, please? And this is the result of, you can see in the obturator foramen, the osteotomy here. And here, one more, please. This is the ischial spine. Like, so I made the osteotomy here. So by doing the osteotomy here, the ligaments remain attached to the sacrum, but the iliacus is free. So the posterior column can mobilize very easily. Then I put my hand inside of the pelvis, the other hand outside. I hold the posterior column and very easily it elevate like this. Then okay, I can't reduce it, so I hold like this. And I put this flash wiring like a jiggly saw around here and around here. You can see. Then I was tightening, and by doing that, the posterior column was elevating, the anterior column was depressing, and I had a rather good preliminary reduction. Then I fix everything with plates, and you can see this is I don't know how long after maybe it's not immediate because it's already healed, but I have a longer follow-up for this case. Yes, that was maybe a 5 years. This is a 13 years follow-up. This case was published in the book, the AO, the osteotomy books of René Marti. And you can see after 13 years, still it's a barrel of femoral head. So you have to wait long sometimes to be sure that there is not avascular necrosis. But if you follow up patient for a long period of time, you can recognize if you have done a good job or not.
Can you explain through which approach you do the wiring? The wiring.
Because I had at the same time the Kocher-Langenbeck and the Ilo-England approach, I was able to see here the anterior inferior iliac spine, and I was able to see here the greater sciatic notch. So I have a flap of gluteus medius here. So I pass my wire underneath the flap of gluteus medius. I recover the wire here. I put like this. And then I was tightening here.
So you use the wire path here or here?
You know, when everything is already stripped, you can pass the wire almost by hand. It's very easy because you have already passed everything. And you have to be aware not to damage the sciatic nerve, which is a really important issue. Otherwise, this is like the jiggly saw when you are performing the Salter osteotomy. You know, you pass it with some protection, and then it's going to be closing, cutting very easily the bone. It's the same trajectory, the circlage wire.
And what about the osteotomy in the pubic? Where is the incision?
I put the patient in the supine position, in the lipotomy position, with bilateral abduction. I palpate here. It is very easy. There's almost no soft tissue attachment because the distance between the skin and you can palpate yourself. It's almost nothing. Even fat people, it is possible to palpate very easily through the distance is no more than this. You find the bone here, you dissect with the copper elevator, and you have to be aware because in male, where is my finger is the erectile mechanism of the penis. So you have to avoid to damage it. And then you make the osteotomy with a chisel and you clean it, you mobilize a little bit, it's very easy, and you can see what is position. It's in the middle of the ilioischial ramus.
So then you have to
to the ischium, it's going to be thicker. If you are very close to the pelvis body, you are going to damage the erectile mechanism. So you open, you take a look where you avoid the erectile mechanism, and you make the osteotomy very easily.
So in the lithotomy position, that means you have to do it before you turn the patient, right?
Exactly. Yes, that was first step.
Okay, so just to be clear, yeah. Yes? Microphone ต่อให้หน่อย
I have some question about the doing the combined approach in the lateral decubitus position. So I think so how do you usually perform the approach, like anterior first, posterior first, and like the sequence, and also because this is the so-called the floppy position. So I think that when you do one position, then you have to kind of move the patient a little bit. So like if I have to guess, then when you do the posterior approach, the hip of the patient is more oblique anteriorly, right? And when you do the anterior approach, then you would have to flip it back a little bit so you can access it more like in a oblique fashion, but not directly posterior. So how do
the patient is positioned the so-called floppy position. The floppy position allows you to perform the iluminal approach with an internal rotation of 30 degrees. It's not absolutely flat. Then you put the patient in the lateral decúbito for the Kocher-Langebeck. That for me is the habitual position for performing. So it's not a big deal. So, and you move back and forward the patient, or you can position yourself at the back of the patient or in front of the patient. You can perform the surgery with an assistant who is also well skilled in acetabular fracture care, or otherwise, if you are alone with surgeons who are younger than you, you are going to be moving from back to front to back in order to release pieces of bone and check the reduction. The trick is how to position the patient on the table. So I need a volunteer. Who wants to be the patient? Okay. I position the patient like this. I fix it with tapes to the table. I have something radiolucent here to immobilize the belly. The arms are positioned like this. A big pillow here like this. Yeah. So we put some draping here along the arm with a pillow in between. So this part of the trunk is very stable. This is positioned like this, and then you put the patient a little bit much more closer to this border. Okay, that's it. No more. So you move, because this part is fixed, you move like this. You perform the iluminal approach like this. Then you move like that, and you perform the Kocher-Langebeck in this position, according to the standard of the development of the Kocher-Lange, which is flex the knee and extend the hip. And you put a pillow in between, so you abduct. So you relax the abductor muscles. And then, because you have blister here, it should be absolutely radiolucent. What I'm using is a pillow, a cylindrical pillow, and then my patient can move a little bit more. So this part is the most stable part of the construction, and this is rotating along the lumbar spine.
So the bolster is.
The bolster is, yeah.
But one remark is the bolster here is not very rigid, right? So it allowed this part to be like.
You need a lot of manpower. I mean, residents to hold the patient in order to, because one of the inconvenience is if you don't fix relatively well the patient, you can finish trying to perform the Kocher-Langebeck like this, which is a nightmare. But if you put pillows, and try the patient to continue bleeding. Thank you very much.
Okay, so one more question is that when you do ilo inguinal in this position, is it possible to do the AIP approach as well, or you do the original like a 3 windows?
I do the traditional iluminal, but if you want to do anterior intrapelvic approach, finally it's up to you. It depends what you need. You can also cross the midline when the patient is almost, it's not supine, but it's almost, and you can reach the opposite hemipelvis very easily. What you cannot do is bilateral iluminal approach, because you have the first window in touch with the table. You can practice in a cadaver in case you need, because I find this combination of approaches really much more adequate in terms of soft tissue handling than the extended ilofemoral approach. Do we have time to some other case? Is someone else bringing cases?
He has one case of pelvis malunion for consultation with you, or you want to do your case first? Oh, okay. Okay, and then maybe we come back to your case. So you stop share. I will share the case. Malunion pelvis ของโยใช่ปะอันนี้เนาะ it's from Dr. Yanin, so maybe I let him do the presentation. Let me share the screen.
So this is just consultation because I haven't done anything with the patient. Yes, the patients came to me accidentally in my clinic. I think probably 3 weeks ago, and she was performed surgery from another hospital. Yeah. Okay. This is a 30 years Thai female, no underlying disease, and she came to my clinic with right buttock pain, and actually she had a history of motorcycle accident probably 2 years and 6 months ago, and she was there as a pelvic fracture, and she was performed a surgery from another hospital with open reduction and internal fixation. Any other clinical examination is quite normal. Let's go to the positive finding. She was tender at the right sacral area and pubic symphysis. Limb length discrepancy probably right side shortening probably 3 centimeter. Neurovascular was intact. This is her gait. Yeah. The problem is right shortening 3 centimeter, and she feel pain on the right pelvis, on the right sacrum at the buttock. This is the X-ray that I saw her the first time. AP view, this inlet view, this outlet view. This colonal view. Yeah. Sorry. Okay. Right here. It's okay. It looks like S1 is already filled with the L5. You want me to go? Okay. Axial, sagittal view. 3D reconstruction. Let me try. Okay. Okay, I just have all this, just only this information. Just can start to go back. Okay. The first thing that I did at that day, I call to Dr. Rahut and send him a video of this video. But I don't know, because I don't have any ideas how to deal with the patient, because I never do something like a late case or reconstruction before.
It's difficult for a beginner because one of the problems you can see is that there is an affection of the L5S1 articulation, and it is already breached by the piece of the sacrum. So when you have something like this, one of the goals is try to fuse L5 with S1, and it is already happened. The problem is it's fused in a bad position, and for that reason, someone is tempted to try to improve the relative position of both of them. The problem is, while you try to improve the position, you are risking damaging L5 and S1 at the same time, especially if the patient has no previous lesion, because one of the possibilities is try to recreate the old fracture line, and this is creating such a risk. Some other possibility is performing an osteotomy lateral to the already fused mass and try to do a cranial migration of the right hemipelvis, which is possible. You can perform an osteotomy at the level of the SI joint or an osteotomy parallel to the SI joint. You can create a big contact area over there, and you can slide this osteotomy and then fix all together the osteotomy and the previous fracture line. You can put a screw that goes from the iliacus into the body of S1 and forget about the deformity as a problem. Just, I mean, the deformity of S1, L5S1, but you are going to be creating a deformity in a different plane in order to compensate that. But you need to release everything that's soft tissue in the back, release everything that's soft tissue in the front, remove the plate, clean the symphysis pubis, put the patient in skeletal traction for a while, improve the quality of your reduction. This is demanding and it takes time. If she is complaining because of the leg length discrepancy and the pain is related to the fuse situation of the L5S1 and not because of a compression of the root, because this is another kind of animals. If you have the already compressed L5 root, you need to decompress it. And sometimes you need to decompress in the front because the compression probably is related to the passage of L5 in front of the ala of the sacrum. The other possibility is to make the shortening of the opposite hemipelvis, which is much more easy to be performed. And in a given sense, it's much more predictable. You remove the plate in the front, you clean the symphysis pubis, you make a vertical osteotomy, as I showed before, from the iliac crest to the greatest sciatic notch, and you can manipulate, you say, look, I want to correct 1 centimeter, 2 centimeters, and you can see the different height, the resultant different height of the iliac crest. When you are at the level of height you wanted to have it, that's fine, because you are addressing, by doing that, the leg length discrepancy and the sitting imbalance. If the pain in the back is related because the sacrum is ununited, you fix the back and you promote the healing of the back, that's fine. But if if the problem is related with entrapment or L5 root, you need to go and release it. So it doesn't matter if you shorten the opposite hemipelvis or you lengthen this one, the entrapment should be addressed as a different entity, which is not very easy to perform, is to make an osteotomy where originally was a fracture line without taking the risk of damaging the root, especially if you have limited experience. So I don't know how well experienced you are, but in my hands, with a case very similar to this one, I made the lateral osteotomy. I discussed the case with my colleagues of spinal surgery. If they wanted to correct the bridge, they say, no, we are going to do nothing. So I leave the bridge as it was. When I received the patient, I made the osteotomy of the lateral mass or at the level of then I fixed everything, but I allowed the bridge to remain in place. So there are different ways to think about this. And for me, the very important issue for the decision-making process is L5 is entrapped or not. So probably you need to open in the front first window with the doing it and check what's going on with L5. And in my case, what I have done is a trench in the arterial aspect of the sacrum in order to release and accommodate L5 into this position because it was under tension. How are the patient from the neurological point of view? Is she okay?
Right now, the intact. It's okay.
So how?
What I concern right now is that if I do something like a corrective osteotomy, I concerned about a complication because right now she doesn't have any problem with a neurological deficit or something like that.
So how do you differentiate the L? How you make diagnosis of the L5 entrapment? Do you have any?
It's not easy because the symptoms are very similar to disc herniation, but you don't have any herniation at all. So if you take an MRI and you can, there is a special technique for the recognition of the L5. In my hospital, there is a radiologist. She is doing, I don't know exactly how she is performing the technique, but probably you can figure it out. And she can continue, he can trace L5. And if you recognize that there is entrapped in scar tissue, you can go by the front and release it. Sometimes it's entrapped in bone formation.
So in your opinion, if we correct at the side of deformity, the easiest way is to osteotomize just lateral to the SI joint, right?
Yeah.
What about when you compare to shortening of the normal side? What do you think?
It's easier to make the shortening of the opposite side, but if you need to, for sure you need to fix the. Can you go back because it is a non-union of the sacrum?
Yeah.
And you need to treat the non-union.
You can see an X-ray.
No, I've seen something in one of the pictures. Oh, there was a CT
scan?
CT scan, okay. This view?
Probably. Or it's not a complete non-union, but partially ununited. This is fixed. There you have a gap. And then you have the coronal cuts. The SI joint is already affected. There. Go back. There is an ununited anterior component. Go back. Back. I don't think it's a big deal finally. The other possibility, you can cut here, but very carefully. If you are going to cut here, I recommend to do it by the front. If you are going to cut here, you can do it by the back, because here it's very close where the L5 root is. And if you cut along the SI joint, you can have a big surface area, and then you are going. You can also finish with a spinopelvic instrumentation or fusing the opposite side in order to have completely fuse the L5S1 space. So one possibility is make the lengthening of the right hemipelvis. The other is the shortening of the opposite hemipelvis. But maybe it's too much surgery for a patient who is complaining of very little. So you have to be sure that you are not going to be affecting L5.
If I choose to do a shortening, which location we gonna do a osteotomy? Which location?
To the act wing to the greater sciatic foramen.
Like this. From the iliac crest to the greater sciatic notch, and then you do like this. You push with the leg and you check the height. It's you're creating Margane fracture.
Okay.
So you push, you hold with the clamp, and you elevate. And if your cut is very smooth, you can correct up to 2.5 centimeters without any problem. No more, because otherwise you are going to be impinging the sciatic.
So that means I have to cut here and cut here, or I also
No, here you need to release the symphysis fluid.
Oh, okay. Just release it. Okay.
Because you have to correct the symphysis fluid, which is this place. So one possibility is to cut here, put the patient under some traction, correct this side first, try to improve the quality of reduction. If you are happy with the reduction, that's fine. And if you need much more correction, make it a shortening here. Sometimes one side is enough and you can correct almost everything. Is she painful in the front also?
No, she complains that only on the back. That's the most painful that she complained.
Yes, because she has the problem L5 is one facet and the fusion. Usually when they are fused, they are not so painful at all.
Yeah, I think, but I don't know why she complains that only on the back side, even
Because
if I see the X-ray.
If the pain is in the deepest part of the buttock, this is related with entrapment of L5. Because L5 is responsible for the innervation of the greater trochanter and the SI joint. And usually when you have a problem in L5 in front of the sacrum, you have problem related to the deepest part of the buttock. What I have done, I made an injection from the back of the sacrum, try to put my needle, a long needle along the alar and put some corticoids with anesthetic in front of the alar to diminish the inflammation at L5 and try to figure out if this is improving. But I'm not so sure because it's really a complex case. I would try to correct at this level an osteotomy parallel to the SI joint, and then no, I'm not going to correct the bridge because I think you are going to be risking too much.
Let me consult Dr. Rahut. Do you want to come here again?
Maybe next year.
Okay, thank you. Okay, thank you, Dr. Yan.
Thank you,
from
Doctor.
Pamungkut Hospital. Okay, so I think yeah, I mean maybe do we have any case from you guys? No, I think nobody dare to present. Okay, can I ask opinion of one of my case? Okay. Because so I just want to ask your opinion of one case. I will show. Okay. I show this case, 33 years. He was fell from height about 5 meters, and then went to a local hospital, and then she was treated conservatively, but now he cannot walk. So first he came to me was about 4 weeks, but by the time we got to have operation, maybe 6 to 7 weeks. And this is X-ray. Is a AP view, so it's a both column. With some, I don't know if you would call this some callus or not, because by your standard, a little bit callus. Okay, but in the obturator view, I see a lot of callus around the spur sign. And I think a lot of callus here start to a little bit. And in the outlet view, I see a lot of shadow here and here. So this is a CT scan. Okay, so we see already some, I'm not sure if you would call callus or not, but some here.
Yes, it has color, but it's not such a color.
Okay, so you see white things, okay, like
Yes.
cotton.
It is removable
And here a lot,
and cheesable.
a lot here. So for me, I think this is quite significant.
To say no?
Scar. No.
Okay.
I mean a lot, but still.
For you, it's a lot. Okay.
Yes. And
Look,
I think, yes.
to put this in perspective, if you can see the old fracture line, it's not enough callus.
Okay. I mean, if it's not enough for you, it has to be bone bridge already. Okay.
No, it should be absolutely fulfill the gap.
Okay. So this is my due definition. So next time.
You know, usually when you are defining fractures, there are two different kind of fractures. Those I can fix, those I cannot. So which one is this for you?
I think I can fix. Yeah,
Okay,
because
perfect.
I've already done the case. But see, I still a lot of soft callus maybe.
Yeah.
But I still see the fracture side. But the concern is usually.
May I ask you a question?
Yes.
Do you have a rongeur?
Yes.
Okay, and curette?
Yes.
So let's go ahead.
Yeah. So okay. So I think yeah, I will go. So I'm a little bit concerned of the scar here.
3 weeks, 4 weeks?
Now this is I think by the time I get to do surgery, it was about 7 weeks.
Yeah, because this is too much color for 3 weeks.
Now it's at 7 weeks.
Okay.
So
let me see something inside of the joint. What happens if you do not perform surgery? Is this going to be okay or not? It's not for you.
Yeah. You ask them, right?
Yeah.
Okay. Ask the floor, please.
A young lady.
Young lady. Young lady. ไม่ได้ยินเปิดยังอ้าวเหรอ
It's a
What kind of animal is this one? What kind of fracture? Both column fracture, transverse fracture,
I
posterior
think
wall,
it's a both column.
both column fracture. Okay, is it
Yes.
benign or malign? Both column.
Quite benign.
Why is benign?
It's a just look like a typical both column, I think.
It is difficult. Typical.
typical
Look, the problem with the both column fracture is when they achieve a secondary congruency,
Yeah.
they can be forgiven. And the stability in every acetabular fracture is not related to the cotyloid fossa. It's related to the equator of the acetabulum in contact with the equator of the femoral head. So this patient has an opening of the cotyloid fossa, but the pieces of bone around the femoral head are relatively in a good position. There is not a wide gap or a wide step. So the articular cartilage have the tendency to heal when the step is smaller than its width. And in this case, if for any reason you cannot operate, it's not going to be perfect, but it's not going to be so bad. The hip joint can survive a long period of time, especially because it's not severely medialized. When it is severely medialized for a both column fracture, it also has a secondary congruency. But the patient is going to have a mobile joint inflection and extension, but it's going to be limited in rotation and adduction, abduction. If the patient has a posterior wall component associated with the both columns, so the prognosis is going to be deteriorated. Of course, I'm not arguing that you have not to operate, because if you take a careful look, you can see there is something wrong. And if we take a look to the other view, if the major displacement is in the posterior column, so the prognosis is going to be jeopardized. But if for any reason you cannot operate this patient, it's not going to be such a disaster as if it were a transverse fracture with the femoral head incarcerated in the fracture line and a breach of callow formation. Or am I arguing against a surgical procedure? No, I'm arguing in favor that you have to obtain by surgical means something which is much better than what you can obtain just watching and waiting. So the surgeon has the obligation to obtain a real anatomical reduction because he has already had a non-surgical secondary congruency, which is going to be working okay. So this is not for a beginner. This is for someone. I'm going to tell a story. Once I was in Paris, and Le Tournelle was going to fix an anterior column fracture that was like this, very limited displacement. And I came from the United States 1 year before, where those kind of fractures they didn't treat it at all because well the gap is not so big. So because of that, I asked Le Tournelle, Chef Professor, why are you going to operate this kind of fracture? Because it's very limited displacement. The answer was very Le Tournellian, because I can leave it better. So if you cannot improve after your surgical treatment, the previous condition, you shall not operate. That means that you have to train hard in order to obtain something much better than Mother Nature. Okay, go ahead. So approach.
Yeah, so
traditional approach for this should be.
Yeah, so but I usually I would go with the combined approach, but I had one quite bad experience about the supragluteal artery injury when I do the case that I have to clean the area here.
It's going to bleed.
Yes. So because I think because the
Do you have a Foley catheter?
yes.
Okay, in case it's bleeding, you put a Foley catheter, inflate it, and wait until the bleeding is going to be stopped.
Yes, you can put the balloon in the sciatic foramen.
Not for a long period of time, and otherwise you're going to be compressing the sciatic nerve.
Okay. But in this case, it's because your reason, because you told if I want to do the operation in this case, I want to make sure that I really have the good reduction, because then it's not worth the trouble. So I was thinking maybe if I do just the combined approach, I cannot, clean everything on the lateral aspect of the ilium. So in this case, I did the EIF. Maybe it's too much, but because I'm not sure if I do only the combined, I can clean everything around here. That was my feeling, because this is very close to the artery and then just directly below the abductor muscle. So usually if it goes a little bit more anterior, you can get it from the front. If it's a bit more posterior, you can get it from the back, right? So I was not sure. So I did the EIF, which I was, so I didn't have much experience, but yeah, I did the EIF. So this is the anterior part. This is the lateral circumflex artery. And this is the dissection going to the back. We lift up the abductor. And now you see here, all here is the healing, the soft tissue healing, or some bone. You can see there's a lot coming up.
You have bone graft.
Yes, I have bone graft. And then I start to release the rotators and do the osteotomy. And then, I can clean everything going to the SI joint. And actually, you cannot see it clearly here, but you can see the pedicle of the superior gluteal artery coming out here. So
if you damage this artery right now after performing the extended femoral approach, the whole bistec is going to be
dead. but the callus is so close to this. So yeah, I think at that time, I think it was a good decision to do this. So this is the spur. And then, after that, I have to this part is already healed. So I have to recreate the fracture. And then I have to go inside to release also the callus from the front. Yeah, and then I just, now everything, the reduction is quite straightforward because we see all. So reduce with the Jungbluth clamp. And then, it's just fixation, straightforward. So this is to compress also the anterior column and fix with the LC2 anterior column screw. Yes, and then release the posterior column and then do the plating. That's it. And then just closure. So this is the reduction. So I think
could you go back?
Yes.
Let me analyze.
I think maybe still a small gap in the posterior. I didn't get all the posterior back.
Okay.
but I think the dome, the weight bearing dome was okay. So just look at the. So the anterior column is very good reduction, but I still have some gap there and in the posterior. But I think at least the hip is a little congruent. You want to go back again?
Yeah. Up there, please.
Sorry.
And then move it. No, move it forward, but gradually to see details. There is a residual gap, not
Small
very
gap.
big. Yeah,
In the anterior column.
yeah.
But this one I cannot reduce properly.
Because I have the sensation that this is for the anterior approach.
Better to go from the anterior.
Because this is part of the quadrilateral surface attached to the posterior column. And in my hands, it is easier to release it from the anterior approach. So that's the reason I prefer to combine approaches.
Yes, because it's very difficult to go medially. That's the only thing that I feel that I cannot control
From
the
back.
medial. Yeah.
The only possibility, if you are going to perform the extended iliofemoral approach, is develop the anterior component, which is an extra to the extended iliofemoral approach, which is opening the front. And while you are doing this, you are going to have a big piece of bone without vascularity. So, because the problem is in the quadrilateral surface and the posterior column, which is attached to the quadrilateral surface. So, and it was already with callof formation at the very beginning. So
now it's about almost a year. He was my fellow when I did this. So now it's a year out, but he's still okay. But he was limping for like 8 months.
yeah, this is the problem with extended approach. When I did follow Letournel cases, you know, even in the hands of the master, the limping of his cases were almost 1 year. So because the abductor muscle remained very weak.
So you think combined approach is better?
This is my experience. I feel much more comfortable in combined approaches.
So would you, in this case, you would have to do also the osteotomy, right? To from the coker.
Yeah.
So you combine elonginal and then coker with osteotomy.
Yes.
Okay.
Look, this is not the Bible. It's what I do.
Yes,
I'm
yes.
doing.
Okay. Thank you.
You're
So I
very
think maybe if we have time for one more case for you, and then we finish.
We can try one more case.
Okay. I hope not too tiring for you. So, or do anyone have any case to discuss? Okay. Yeah, microphone, please. So.
Do you want the geriatric pelvic fracture?
Hello. So I have one question about Dr. Rahut case. Like in case like this, maybe I was thinking like if we do the combined approach with trochanteric osteotomy, would it be possible to clear all the callus on the lateral side, or would in your hand what would be your opinion?
I think you can clear the callof from the lateral aspect, but if it's not enough, you can get from inside through because it's a fracture line that goes from inside outside. So you can clean underneath the muscle from inside also. When you abduct the hip, you create conditions to work underneath the abductor muscles. So you don't need to see the whole fracture line completely. You perform the extended iliac femoral approach, you're going to see the fracture line like this. If you perform a Kocher-Langenbeck approach, you are going to see the fracture line in this direction. So this is your view, but still you can see it. And if you need, you can clean from inside, because this is a fracture line that goes from outside to inside. So you clean from inside, you displace the fracture, remove the calloid formation, and don't need to open completely the outside. But this is my point of view. If you discuss this issue with Keith Mayo or Michelle Oransky, who have a tremendous amount of experience through the extended iliofemoral, probably they will say, for me, it's extended iliofemoral. And I have arguments when I have a bad displacement of the medial aspect of the quadrilateral surface or something which is medial to the iliopectineal eminence. I don't like the extended iliofemoral approach. I prefer the capability of the ilioinguinal approach, and I can accept the limitations in certain areas of the Kocher-Langenbeck in comparison to the extended iliofemoral approach. If I'm going to deal with one problem, which is intraoperative bleeding, because I have two approaches at the same time, I do prefer to deal with this instead of dealing with heterotopic bone formation and weakness of the abductor muscle during a while. But finally, the surgeon has to take the decision which problem he wants to address much easier. And you are going to take your own way to resolve it.
Thank you.
So I had that question. That's why I choose, Okay, so please, do you want a geriatric or open pelvis for the last case? Open. Okay, so we don't like old people, yeah? So maybe open, please. Yes. So I think this is for the last case for today. So also thank you everybody who's joining us from the Zoom. I think during the peak, it was about 50 from the Zoom. So thank you very much. I saw you open. Yeah, that's it. If you have any question, you can type it in the chat. If we have time, I will ask for you. Okay, so I think this is the last case for today with about the open pelvis. Okay.
So this is a case, it's a young individual, only 32 years old, referred to us. He was working in a salt mine in Rio Negro, which is a province 1,000 kilometers south to Buenos Aires. He was crushed by a mine machine. He was locally treated by local surgeons with an X-fix, colostomy, and sent to our place. So actual problems is posterior instability, which is not addressed, anterior instability, which is partially addressed by the X-fix, the acetabular fracture, the rectal tear and the colostomy, urethral tear, he had a suprapubic catheter, and detaching of the erectile mechanisms of the penis. Okay. Who wants to be the surgeon? We need a volunteer.
I think I will try. So this one, I'm not sure about the open wound. Is it right at the groin, or is the at the
No,
feet?
it's around the anus.
Oh, okay. So this so we can see that there's a looks like a T-type on acetabulum fracture on the right, and bilateral SI joint dislocation from this one, I think. So is all the whole ring is disrupted. So but the wound is actually at around the anus, right? So I think we don't really want to go in to from the anterior right now. So the thing that we are concerned the most is the posterior instability. So I think in this case, initially after receiving the patient with only the egg fix, so we would try to stabilize the posterior pelvic ring using either so at this point, maybe C-clamp doesn't help anymore. So maybe using the SI screw on both sides, or we have to see the CT if it's the configuration.
This is what you want.
Okay. So it's a zone 3. Then it's zone 3 on the left side and on the right.
So we have a rare combination: a sacral fracture plus an SI joint dislocation.
Mm-hmm.
And in the opposite side, we have a fracture of the acetabulum. If you have a careful look, it's the family of the transverse fractures, isn't it?
Yes.
Are you happy with the X-fix in place?
I don't think this X-fix help so much.
Okay.
Because
so what do we have here?
It's outside.
Okay. And then you wanted a CT scan. Okay, here you have the CT scan.
So on the left side is combine the sacral fracture and the SI joint dislocation, and it looks like a transverse with some joint impaction on the right.
Okay. So today is the day 5 after the accident, and you received the patient. What are you going to do?
So at day 5, I think the concerning thing right now is the posterior stability. So
Okay.
I would try to fix the posterior, but with
which kind of approach?
I think maybe combine because looking at the CT, then the sacral is not really displaced so much, but we want the SI joint to be reduced, and then fix both the SI joint and the sacral with the screw.
Okay.
Maybe 2 or at least 2. So I think we'll be open on the lateral window of the iliaconal, and then do open reduction of the SI joint and put the screw in.
The lateral window has an X-fix in place and a colostomy.
Oh.
Sorry, it wasn't my fault.
So probably just close reduction.
First of all, X-fix exchange. And you can see the lesion of the... Okay. You cannot see the anus anymore. The rectal tear is with the destruction of the sphincter. And it has one lesion of the urethra, and you can see the contrast, stop. So we decided to organize the case. We remove the X-fix, we put a supraacetabular pin bilaterally, and the winner is The winner is close reduction.
Yeah.
Take a look to the SI joint. By close reduction, we are able to improve the quality of the SI joint and the fracture of the sacrum. So then 2 days later, we put 2 percutaneous screws. The main question is why not on day 1? Yes, because we wanted to change that and we were in a hurry to resolve everything and we needed to do something more with the rectum. We asked the people of the general surgery department if they are going to reconstruct the rectum. It is impossible to recover the function of the sphincter, so don't leave the piece of necrotic or don't leave in the middle of my pelvis the disaster of your rectal tear. So that remove everything. You know that one of the surgical techniques is to perform the Hartmann procedure, which is you have a colostomy here, and then you restore the transit later on. So I did propose to treat this as if it were a rectal cancer and then ask the general surgeon to perform a Miles procedure. The Miles procedure is the amputation of the rectum because it happened to me in another case. They performed the Hartmann and then I have a fistula mucosa and it was creating mucus and mucus and mucus, and it was a disaster from the infectological point of view for nothing because the patient will never recover the sphincter function. So, and then it happened because of that, it had a 9 days post-trauma, 3rd look, retroperitoneal abscess. So the proposal was, I remember, okay, it has no more rectum, it has a retroperitoneal abscess. And I remember at the time I was a medical student and I've seen some vaginal delivery. So we can open the perineum like in the female and make a episiotomy for the release of everything from the retroperitoneal space. So we made this discharge and we clean everything, all the abscess through this incision in the peritoneum. And by doing that, we transform a complex soft tissue situation in just a bony problem. So this was an abscess of the ischiorectal fossa. The ischiorectal fossa is a space which is in between the rectum and the ischial tuberosity. In this particular case, no more rectum at all, so it was very easy to clean it through the ischiorectal fossa. We put a vacuum seal, and at that time we asked the urologist to make, look, if we are going to wait too much, this is going to be full field cover of scar tissue, is going to be a disaster. And you are going to repair the urethra through the perineal approach. And the approach it was already done. So why don't you try to repair it? So my colleague put an endoscope through the penis and then another thing through the incision in the perineum, and then he restored the anatomy of the urethra. Now the patient is just an orthopedic patient. No more general surgeons, no more urologists. Day 29. Now it becomes, and it was infected, of course. So we needed to clean everything before performing the surgery of the acetabulum. And we decided to perform the surgery of the sternum through a posterior approach, which is the cleanest part of the pelvis in this particular patient. So at day 29, we performed this surgical procedure. And if you take a careful look, you cannot see the femoral head. So the acetabulum is empty, isn't it? You know why? No femoral head here. This is a surgical dislocation. So we restore the anterior component of the fracture through the surgical dislocation. We fix it, then we reposition the femoral head to check that everything was okay. Now the femoral head is in. The control of the screw of the anterior column, the plate of the posterior column. And now is the moment to fix the pelvic symphysis. So we fuse this is the reconstruction of the pelvic symphysis, and you have here cigars of cement plus antibiotic And this is the CT scan of the sacral fracture. And this is 1 year follow-up. And at this moment, the erectile mechanism of the penis was okay in position, but the patient needed some help to improve his personal condition. So at the end, I did remove the cigars of cement, and this is the follow-up. I lost follow-up of this patient later on because he went back to his original place, and then it came the pandemic time, and he never returned to Buenos Aires. I made a phone call to him and no, he's doing okay. He has some urological, some erectile dysfunction. He's taking some pills, but he is walking without any big problem until now. Sooner or later, maybe he's going to have development of arthrosis, but it's not such a bad situation for a total hip replacement if he needs something like this. Okay, that's it. Conclusion: apply principles, combine principles, challenge principles, disagree with principles, develop new principles. Thank you very much for your attention.
Thank you. So I think we are very tired, but I think it was a very good discussion. Yeah, you have any last question for Professor Carlos? Because I think this is a very special situation that he's here today. Yeah, and I think we learned a lot. It's a lot of application and not non-theory part, but I think it's very difficult to get knowledge like this from the usual meetings and reading the text or something that we are used to. So do you have any more questions? I think they are overwhelmed. Okay. So do you have any comments or anything you like to say?
I would like to say thank you very much for being the whole day with me and giving me the opportunity to share experiences. It was really very fruitful for me to see how well developed is acetabulum fracture care here in Thailand, and hope we are going to meet soon. I don't know where. This is very small world. Thank you very much.
Okay, thank you. So I think we would like to end and thank you very much for all joining in the Zoom too. So now there's 26, there used to be 50. So thank you very much. And yeah, we'll keep in touch, and then we will, oh yeah, I have a last announcement to make. So we will have our pelvic course for the Thai Orthopedic Trauma Association. I just to show you on the 14th to okay, so I will end this with desktop ก็ได้ Oh, it's not possible to share. It's okay. I cannot share the screen, but it's during the 14 to 16 December. So if you are interested, you can try to register for our pelvic course. So thank you very much, Professor. I hope to see you again sometime soon. So thank you very much, everybody, for your participation, and have a very good day. Okay, bye-bye. Bye-bye. Okay. I think we can have one group photo, please. Okay. Stop recording. อ๋อได้ครับลด
เอากรุ๊ปโฟโต้เร็วๆมาข้างหน้า